machinery operates entirely in the background without a single conscious thought. Patients often isolate themselves to map the exact spatial coordinates where the biological machinery fails at the back of the throat, threatening to spill into the windpipe and cause severe lung infections. Sometimes physical roadblocks cause this hazard. A patient might develop a continuous X-ray. Once identified, speech-language pathologists introduce targeted physical maneuvers, like an exaggerated chin tuck, or modify diets with thickened liquids, using gravity and positioning to safely guide food downward. In severe cases where they file feeding tubes directly through the skin into the stomach, ensure to one strict biological imperative: protecting the airway before the food ever reaches the esophagus. Moving downward, we enter the second zone, the esophagus. This vertical tube forcefully transports food internal webbing, thick tissue rings, or allergic inflammation like eosinophilic esophagitis. The obstruction isn't always a physical mass. Sometimes it's a loss of mechanical pressure. In a condition called achalasia, the nerves surrounding the esophagus die off. The muscles lose their rhythmic contractions, and the lower valve rigidly refuses to open, backing up food like a clogged drain. Doctors investigate this zone using an endoscopic camera to check for physical blockages and a manometry probe to measure muscle strength. This split-screen visualization compares the smooth equally direct. If an internal stricture blocks the tube, a gastroenterologist inflates it, physically stretching the tissue. If tense, unyielding muscles are causing the jam, doctors can inject Botox directly into the sphincter to force relaxation, or perform a specialized surgery to cut the frozen muscles entirely from the inside. Lower esophageal treatments treat the body as a plumbing and wiring system. Success relies on clearing pipes and restoring necessary pressure to push solids into the stomach. Restoring a safe swallow returns a patient to the social world. They move from eating in isolated fear to sharing meals and conversations at a crowded dinner table. The human swallowing mechanism relies on dozens of intersecting muscles, nerves, and valves. Yet by accurately exactly where that system halts, physicians can deploy targeted mechanical solutions to bypass or repair the damage. This makes early assessment critical. Rather than adopting dangerous eating habits or quietly tolerating the discomfort, patients experiencing this difficulty should seek an evaluation from a gastroenterologist or language pathologist immediately. Repairing the biological transit tube ultimately achieves a much larger goal. For most of us, eating is an afterthought. A bite of solid food and feel a sharp burning sensation behind your breastbone, a routine reflex becomes a source of dread. This pain signals a breakdown in a complex physiological relay race. A healthy swallow involves over 30 muscles and multiple cranial nerves working in 3 distinct phases. It begins in the oral phase, where you chew and mix it with saliva to form a bolus, which the tongue then pushes toward the back of the throat. In the pharyngeal phase, timing is everything. A flap of cartilage called the epiglottis folds over the windpipe to protect your airway, while the upper esophageal sphincter opens to guide the food into the throat. Finally, during esophageal phase, rhythmic muscle contractions called peristalsis wave down the length of the tube, driving the food into the stomach as the lower esophageal sphincter relaxes to allow entry. When any part of this process causes acute pain, it is medically classified as odynophagia. This differs from dysphagia, which refers to the physical sensation of food getting stuck. Odynophagia is the specific experience of pain during the act of swallowing itself. This sensation indicates that the esophageal lining has been compromised. The pain acts as a warning that structural, chemical, or inflammatory damage is occurring somewhere along the anatomical pathway. One primary source of this damage is infectious esophagitis. These infections are most common in patients with weakened immune systems. Those undergoing chemotherapy, organ transplant recipients leave distinct signatures on the esophageal wall. Candida albicans creates thick white fungal patches. The herpes simplex virus results in a cluster of small, shallow ulcers. Meanwhile, cytomegalovirus, or CMV, produces large, deep, isolated erosions that penetrate when leading a persistent burning sensation. Medications can also cause. This occurs if a tablet, such as an antibiotic or an NSAID, lodges in the throat because it was swallowed without enough water or taken immediately before lying down. More severe chemical damage occurs through corrosive injury. This cross-section shows the difference. Acids cause coagulation necrosis, which forms a clumping scab on the surface. Alkalis are often more dangerous, causing a fungal infection, a trapped pill, or corrosive chemicals. The resulting inflammation sensitizes the nerves. This damaged tissue, triggering an immediate pain response. Some causes are linked to the immune system. Eosinophilic esophagitis is an allergic condition where white blood cells called eosinophils accumulate in the esophageal lining. This is frequently seen in patients who already manage asthma, eczema, or specific food allergies. The most critical concern is esophageal cancer. In these cases, the pain of odonophagia is often accompanied by progressive weight loss of food physically blocking the throat. Early detection is vital, as these tumors can rapidly invade the surrounding tissue. Differentiating between a simple infection and a malignancy requires a clinical evaluation. This process begins with a physical exam and a detailed history of when the pain occurs and what types of food trigger. To see the damage directly, clinicians use an upper GI endoscopy. A flexible camera is guided down the esophagus, providing a high-definition view of the lining. This allows for immediate identification of ulcers or growths and enables the doctor to take small tissue biopsies for testing. If a structural issue is suspected, a barium swallow test provides a map of the esophageal movement. As a contrast liquid, X-ray imaging shows the flow in real time. If there is a narrowing or a motility disorder, the fluid pools above the obstruction, revealing the exact location of the problem. Identifying the specific mechanism of infection, a chemical burn, or a structural narrowing is the only way to develop an effective treatment plan and prevent long-term damage. Treatment is dictated by the laboratory findings. For infectious esophagitis, physicians prescribe specific antifungal or antiviral medications to eliminate the pathogen and allow the esophageal lining. Patients often use proton pump inhibitors to stop acid production, triggering further immune responses in the esophageal tissue. Mechanical issues require direct intervention. Lodged objects are removed endoscopic surgery, chemotherapy, or the placement of a stent to keep the airway and food passage. Ignoring painful swallowing can lead to severe complications. Beyond the risk of malnutrition and dehydration, chronic inflammation can cause the esophagus. In extreme cases, lead to a life-threatening perforation of the esophageal wall. Many of these conditions are preventable. Treating acid reflux early, taking medications with plenty of water, and remaining upright after meals. When the cause is addressed, the esophageal lining heals. The coordinated contractions of the swallowing reflex return to their natural state, allowing food and liquid to pass into the stomach without pain. Odonophagia is a clinical sign of active esophageal injury. Because the causes range from requires a professional medical evaluation to ensure the pathway remains healthy and functional.
If you found this video informative, please like and share, comment what you would like to see next, and subscribe to the channel to get notified about future informative videos. If you found this video informative, please like and share, comment what you would like to see next, and subscribe to the channel.
This is part 1 of the videos about palliative care for esophageal cancer. Right now, we are looking at a healthy human esophagus, a smooth, muscular tube that effortlessly carries food and water down to the stomach. But for patients with advanced esophageal cancer, this clear pathway becomes a dead end. A malignant tumor grows in. Many patients are diagnosed. The disease it starts as a slight difficulty swallowing, but eventually progresses into a complete, even normal saliva into the stomach. When a cure is no longer physically possible, the medical strategy pivots entirely to palliation. The goal shifts to reopening that locked passageway to minimize suffering and maximize the patient's quality of life. Clearing this blockage is a direct the obstruction. Doctors often turn to a mechanical bypass relies on physically wedging the collapsed pathway with early forms of esophageal intubation. In the historical Celestin's tube procedure, a pilot wire passes through the stricture and out an incision in the stomach. This wire drags a rigid tube down until it wedges against the tumor. doctors use flexible endoscopes to deliver self-expanding metal stents directly into the narrowest part of the stricture, and the patient wakes up with instant relief from their dysphagia. But forcing an artificial tube through diseased tissue carries physical risks. About 10% of the time, the esophagus can perforate. Patients might also suffer from severe acid reflux, or find that the tube itself gets clogged with food or overlapping tumor growth. Mechanical solutions secure the airway and allow the patient to eat immediately, but they do person to adapt to a permanent physical stressor lodged inside their anatomy. When a tumor shape makes a rigid tube impossible to place, especially highly irregular or exophytic tumors, doctors shift to a second strategy, energy ablation. Instead of stretching the tissue, they use thermal energy to clear the path. In laser photocoagulation, a fiber optic tip delivers pulses of light to vaporize malignant tissue, clearing a path upward. For higher tumors, bipolar dithermy preferred. These probes use direct thermal heat to destroy the blockage, offering a safe alternative. Because these thermal tools vaporize the obstruction rather than stretching the esophageal wall, the incidence of perforation drops down to between 5 and 10%. However, this precision comes with a physical trade-off. Energy ablation does not work instantly. The patient has to endure a waiting period of up to a full week for the treated to swallow properly. And if the tumor aggressively regrows, the patient will have to return for repeated sessions just to keep the passage clear. By choosing energy ablation, doctors trade the immediate, riskier fix of a mechanical stent for the destruction of tumor cells, requiring the patient to push through a tough recovery week to regain their ability to eat. For specific superficial cancers, there is photodynamic therapy, or PDT. A photosensitizing chemical is injected into the patient's bloodstream 48 hours before the procedure, where it settles into the malignant cells. During an endoscopy, the doctor floods the area with a specific wavelength of red light. This light activates the chemical, triggering a cytotoxic reaction that destroys the tumor's blood supply, causing the tissue to wither away. But PDT is highly restricted. Large, advanced cancers, it leaves deep tissue intact, causes a risk of hemorrhage, and the symptom relief is often poor and delayed. When a tumor creates an absolute, impassable blockade that rejects both mechanical stents and thermal ablation, the absolute final option is a gastrostomy, a surgical feeding tube placed directly through the abdomen into the stomach. While a gastrostomy needs vital calories to keep the body alive, it cannot restore the primary function, left unable to swallow their own saliva. To achieve this, an open, functional turn of basic human autonomy. It allows them to eat soft foods and comfortably manage their own saliva, removing the constant fear of choking. Palliative care at this stage uses engineering and physics to prioritize the patient's comfort. It is about using mechanical and thermal tools to restore specific bodily functions. Medical science cannot always extend the timeline of advanced cancer, but these structural tools ensure that the final months are defined by dignity, not distress. Stay tuned, as we will explore more interventions and symptom management strategies in part 2 of our series on palliative care for esophageal cancer.
Welcome to part 2 of our When Cure is Not Possible. Treatment focuses on relieving symptoms, restoring swallowing, maintaining nutrition, controlling pain, and improving quality of procedures, radiotherapy, chemotherapy, and other supportive treatments using detailed 3D medical animation. Let's begin.
In a healthy state, the esophagus functions as a simple, vital muscular pathway for sustenance, moving food and liquids to the stomach. When squamous cell or adenocarcinoma tumors develop, the mass is often permanent. Over half of advanced esophageal cancer patients are unfit for curative surgery. When normal swallowing is blocked, a patient's health and quality of life deteriorate rapidly, as nutrition and hydration become physically impossible. In these cases, medical strategy shifts from a surgical cure to an aggressive campaign to bypass the obstruction and restore the patient's ability to eat. One immediate physical solution is self-expanding metal stent, or SEMS. Doctors pass the device over a guide wire under X-ray guidance until esophageal pathway. Uncovered metal stents allow esophageal tissue to project through the mesh. This anchors the device, but the tumor can eventually grow back through the grid. Plastic-covered stents block this ingrowth, but lack mechanical grip, making them much more likely to migrate downward. This forces a calculation between the risk of the stent being blocked by new tumor growth and the risk of the device physically into the stomach. If the tumor is completely irremovable and the patient has a limited life expectancy, surgeons may attempt a high-risk bypass operation to manually reroute the digestive tract. These mechanical solutions 5 days a week for 5 weeks. These daily increments eventually sum to a threshold between 5,000 and 6,000 centigrade. This intensity can be difficult to tolerate. High-dose radiation may lead to serious complications, such as the formation of a permanent fibrous stricture or a dangerous fistula between the esophagus and the respiratory tract. A more localized alternative is brachytherapy, with cyclical chemotherapy to attack the cancer cells on a broader scale. Like the disease, their single-agent response rates are often poor, and the cumulative side effects can be debilitating. Modern palliative care increasingly relies on a multimodal approach, combining mechanical, localized, and systemic treatments to address the limitations of each. There is a significant synergy when cyclical chemotherapy, such as cisplatin, is combined with external radiotherapy. This combination produces measurable disease shrinkage in approximately 60% of patients. This response leads to a significant improvement in both the patient's survival and their quality of life. However, combining successful cellular treatments with mechanical stents creates a specific clinical contradiction. When systemic chemotherapy is highly effective, the tumor shrinks away from the esophagus walls. If that tumor is anchoring a metal stent in place, the stent loses its grip and falls into the stomach. Because of this risk, doctors avoid placing stents in patients undergoing effective chemotherapy, opting instead for laser therapy to manage the opening of the esophagus. Palliative care for esophageal cancer remains a high-stakes balancing act between physical engineering and cellular biology. By coordinating these treatments, clinicians can restore the basic dignity of eating and drinking for those facing a terminal diagnosis.
If you found this video informative, please like and share, comment what you would like to see next, and subscribe to the channel to get notified about future informative videos.
By coordinating these treatments, clinicians can restore the basic dignity of eating and drinking for those facing a terminal diagnosis.
A patient who was previously healthy begins to notice difficulty swallowing food. Meals take longer, food feels stuck, and symptoms slowly worsen. Over weeks, even soft foods become hard to swallow. Weight loss begins and weakness sets in. Eventually, even liquids become difficult. The patient consults a doctor. The doctor considers causes of progressive swallowing difficulty, including benign strictures, achalasia cardia, and esophageal cancer. They evaluate whether there's a blockage, a motility issue, or malignancy. If cancer is suspected, further tests are required. The workup is appropriate. Each step builds on careful assessment and imaging.
Evaluating the esophagus begins by observing function. When we introduce a test, like barium, we can visualize the macroscopic flow through the esophageal lumen and map out sudden anatomical bottlenecks. This standard barium esophagram provides a highly accurate initial morphological baseline. By utilizing air contrast techniques, we can consistently detect structural lesions as small as 10 millimeters in diameter. We are looking for specific radiographic filling defects, visible distortion of the normal esophagus. To establish a diagnostic baseline, we contrast the lesion typically presents as a smooth, symmetrically tapered narrowing. A malignant lesion, however, actively destroys the surrounding tissue architecture, creating an irregular, geometrical narrowing. Logical response to these obstructions also differs. Benign data alone is circumstantial. It maps the shape of the defect, but it cannot definitively prove the presence of cancer cells. Because of this limitation, there is an absolute clinical rule. Endoscopy must be performed in all cases where an esophageal cancer is suspected based on the initial barium study. Passing an endoscope direct into the lumen serves 3 critical functions. It allows for direct visual inspection of the mucosa, the extraction of physical tissue through biopsy, and mucosal brushing for highly specific cytological examination. Once cytology confirms a malignancy immediately, diagnosis is complete. The priority is now tumor staging. The central challenge of esophageal staging lies in the anatomy itself. We have to accurately measure exactly how deep the tumor has penetrated through the thin esophageal wall. Diagnosis only proves consider opening the chest. The lesions. Because these tumors often choke off the esophageal tube entirely, attempting EUS is technically impossible in a significant percentage of patients. When strictures block the probe, the fallback protocol requires a return to double contrast barium studies. We use the liquid contrast to map the total length of the advanced carcinoma and locate its distal segment. This fallback has obvious limitations. While barium can successfully reveal secondary carcinoma sites and overall tumor length, it completely fails to evaluate the depth of invasive growth into the wall. EUS provides unparalleled micro-resolution of the primary tumor site, but it is inherently restricted by the very mechanical obstructions the tumor creates. Resolving the local depth is only half the staging process. We also require macro staging to establish resectability for distant metastasis, making CT scanning of the chest and abdomen mandatory. Where EUS works radially from inside, CT evaluates anatomy using external axial slices, stacking top-down views of the thorax. This orientation allows CT to identify tracheobronchial invasion. We cannot accurately assess diaphragmatic invasion because the oblique diaphragm crosses confusingly through flat axial planes. Its primary strength lies lower down, visualizing upper abdominal and infradiaphragmatic lymph node metastasis. To cover the imaging blind spots, surgical adjuncts are mandatory. For lesions in the upper and middle thirds of the esophagus, a bronchoscopy is performed to directly rule out tracheal and bronchial invasion. For adenocarcinomas located in the distal esophagus, laparoscopy is critical. It allows direct vision of transperitoneal spread and superficial liver metastases that the CT. Accurate staging demands a multimodal matrix. No single imaging perspective can resolve both the microscopic wall depth and the macroscopic. For squamous cell carcinoma, this introduces a major clinical paradox regarding radiotherapy. Squamous cell carcinoma is highly radiosensitive. The tissue readily absorbs and is destroyed by radiation. Yet, when radiotherapy is utilized as the sole treatment, it practically never achieves a cure. This chart compares that high theoretical radiosensitivity against clinical biological defense mechanism of the tumor. It is a mechanical process of 5,000 to 6,000 rads. Because of the surrounding, delivering this safely is strictly confined to cervical esophageal carcinomas located higher up in the neck. The theoretical vulnerability of the tumor is entirely negated by the severe physical limitations of the surrounding thoracic cavity. If we attempt to apply those radical curative radiation doses lower down to the thoracic esophagus, it causes devastating collateral damage to adjacent vital organs. The lungs are highly vulnerable, leading to severe radiation pneumonitis as acute biological inflammation cascades through the pulmonary tissue. The esophageal tract itself suffers profound structural damage, resulting in tight post-radiation strictures or the formation of lethal tracheoesophageal fistulas, pericardial effusions, and constrictive pericarditis around the actual clinical utility of radiotherapy for thoracic lesions. It is primarily a tool for palliation, not cure. The palliative protocol utilizes alleviate distress symptoms like severe pain, dysphagia, and active bleeding. Secondarily, it serves as a preoperative adjunct, used to shrink the tumor margins and improve the odds of surgical resectability before an operation. Within the thoracic cavity, radiation is rarely a definitive cure. Instead, it is a calculated biological trade-off, strictly modulated to manage terminal symptoms or clear the way for surgical extraction.
Here's the thing. With esophageal cancer, surgery isn't always on the table. If the cancer has reached distant organs, wrapped around or invaded vital structures, or your overall health makes a big operation too risky, doctors may choose a different path. The goal then shifts from cure to comfort. That's where palliative treatments come in. You might hear about chemo. A small tube-like support is placed to keep the esophagus open, so food and the patient is cared for by a team. Upper GI surgeons, oncologists, gastroenterologists, radiologists, pathologists, dietitians, nurses, and palliative care specialists. The most important message: don't ignore persistent difficulty swallowing. Early diagnosis often means more options and better outcomes.
If you found this video informative, please like and share, comment what you would like to see next, and subscribe to the channel to get notified about future informative videos.
Most important message: don't ignore persistent difficulty. Early diagnosis.
Elastic muscular tube. Within the gastrointestinal tract, cancer here is relatively rare, accounting for only 7% of malignancies. The disease starts. Long before any alarms go off, a patient might notice a vague sense of indigestion, a mild discomfort behind the breastbone, or perhaps slow hidden blood loss resulting in mild anemia. Eventually, these quiet signals give way to the disease symptom, progressive dysphagia. At first, swallowing solid foods becomes difficult. Over time, that internal obstruction tightens until even liquids, and eventually a person's own saliva, cannot pass. What makes this disease particularly difficult to pin down right now is that its biological profile is shifting. The frequency of different cell types and where they appear is no longer following historical patterns. Because the cancer's behavior, triggers, and survival rates change depending on where the tumor originates, we have to map the disease anatomically. By descending the esophagus from top to bottom, we can see exactly how this threat forms and how it spreads. Looking first at the upper and middle sections of the tube, we find the traditional stronghold of the disease. Historically, over 95% of all esophageal cancers occurred right here, taking the form of squamous cell carcinoma. The majority of patients are between 45 and 75, with a sharp link directly to heavy tobacco use and excessive alcohol consumption. But there is also a striking geographic cluster. Incidence rates for squamous cell carcinoma spike across a distinct belt of the globe, stretching from the shores of the Caspian Sea across to northern China. In these specific areas, the triggers are largely environmental. Agricultural practices can lead to the fungal contamination of food stores, carcinogenic toxins. When these are combined with regional nutritional deficiencies, the local risk increases. Beyond diet and habits, structural issues can also create an opening. A condition called achalasia causes the esophagus to severely dilate and lose its ability to push food downward. Patients with this condition face a tenfold increase in squamous cell cancer, often developing tumors at a much younger age. While tumors in the upper regions are dominant pathology is adenocarcinoma. This chart tracks the progression in the esophagus. In several countries, adenocarcinoma now accounts for 60 to 75% of cases, with its incidence growing by 8% every year. This data follows the rise of chronic acid reflux. As stomach acid repeatedly burns the lower esophagus, the persistent inflammation causes the normal tissue to change. It can develop into Barrett's esophagus, where the lining is replaced by tissue similar to the stomach or intestines. Regardless of the cell type, this organ is poorly equipped to contain them. The cancer spreads locally by burrowing horizontally beneath the top layer of healthy tissue, extending up to 3.5 centimeters out from the visible tumor site. Cells can skip the local lymph nodes entirely, bypassing them to seed growths further away from the main tumor. By tunneling invisibly under the mucosal surface and skipping the body's local alarms, the carcinoma establishes a sprawling network long before the physical act of swallowing ever becomes difficult. Because the cancer weaponizes the body's drainage pathways, treatment options, and survival chances, tumors in the upper third drain into a widespread glands in the neck. Because this area is crowded with vital structures and major blood vessels, radical surgery is often impossible. Instead, these growths are frequently treated with radiotherapy. In the middle third, the lymph fluid drains into the hilum of the lungs and the subcarinal glands. Removing a tumor here presents surgical challenges, where the roles of surgery and radiotherapy are still being defined. The lowest third offers the clearest path for surgical intervention. Because it drains into the glands around the stomach and spleen, surgeons can perform an en-bloc resection, removing the lower esophagus along with the adjacent stomach, spleen, and omenta. Instead, it usually kills through local invasion of the surrounding anatomy. Signs like hoarseness caused by nerve palsy or swollen glands in the neck indicate the cancer has reached the trachea, aorta, or diaphragm. Esophageal carcinoma is a highly effective opportunist, driven by uses the physical layout of the esophagus to hide and branch out. Tracking exactly where this cancer lives is the only reliable way we have to intercept it. Here is a tumor at the gastroesophageal junction. Above is the esophagus, a transit tube. Below is the stomach, a holding tank. Surgeons cannot simply remove the diseased section and leave a gap. They must detach the stomach and pull it into the chest cavity, Traditionally, this procedure required highly invasive the patient with large incisions across both the chest and the abdomen. Today, a modern approach achieves this using a robotic platform that operates through 4 or 5 small incisions in the belly. Minimally invasive ports reduces physical trauma and bypass the ICU entirely, recovering fast enough to begin life-saving. Moving the stomach out of the abdomen presents a strict biological limit. Tissue dies without blood flow. This vascular map isolates 2 major supply lines, the left gastric artery and the gastroepiploic arch. Stabilize the stomach, the left gastric artery, and smaller resecting the esophagus cuts the vagus nerve. Without this nerve, the brain can no longer send signal to empty its contents. To counter this, surgeons perform a pyloromyotomy, pyloric sphincter, the exit valve at the base of the stomach, permanently widening this lower valve changes how the stomach operates. The organ relies entirely on the sheer force of gravity to ensure food continues moving into the intestines without getting trapped. Surgeons enter through the right side of the chest to free the thoracic path, keeps instruments safely away from the heart and the major blood vessels grouped on the left. Once the esophagus is free, the massive physical relocation begins. The mobilized stomach slides up through the diaphragm and is pulled all the way out to a small incision in the right, with the stomach now residing in the chest and neck, and the vagus nerves. These are combined with regional nutritional deficiencies, habits, structural issues can also create an opening. A condition called achalasia causes the esophagus to severely dilate and lose its ability. Patients with this condition face a 10-fold increase in squamous cell cancer, often developing tumors at a much younger age. While tumors in the upper regions are tied to specific environments and habits, we find a different landscape as we organ. Moving down to the lowest third of the esophagus, the entrance to the stomach, we hit a different biological landscape. Here, the pathology is adenocarcinoma. This chart tracks the progression in the lower esophagus cases, with its incidence growing by 8% every year. This data follows the rise of chronic acid reflux. As stomach acid repeatedly burns the lower esophagus, the persistent inflammation causes the normal tissue to change. It can develop into Barrett's esophagus, where the lining type, this organ is poorly equipped in them. The cancer spreads locally by burrowing horizontally beneath the top layer of healthy tissue, extending up to 3.5 centimeters out from the visible tumor site. It also uses the body's drainage system to leapfrog across the region. Through dispersed lymphatic permeation, malignant cells can skip the local lymph nodes entirely, bypassing them to seed satellite alarms. The carcinoma establishes a sprawling network before the physical act of swallowing ever becomes difficult. Because the cancer colonizes the body's drainage pathways, the exact physical location of the tumor neck. Because this area is crowded with vital structures, like the trachea and major blood vessels, surgery is often impossible. Instead, these growths are frequently treated with radiotherapy. In the middle third, the lymph fluid drains into the hilum of the lungs and the subcarinal glands. Removing a tumor here presents surgical challenges, where the role for surgical intervention. Because it drains into the glands around the stomach and spleen, surgeons can perform an en-bloc resection, removing the lower esophagus along with the adjacent stomach, spleen, and omenta. The disease rarely spreads through the bloodstream until late in its progression. Instead, it usually kills through local invasion of the surrounding anatomy. Signs like hoarseness caused by nerve palsy or swollen indicates the cancer has reached the trachea, aorta, or diaphragm. Esophageal carcinoma is a highly effective opportunist. Driven by shifting lifestyle factors and internal biology, it uses the physical. Tracking exactly where this cancer lives is the only way we have to intercept it. Here is a tumor at the gastroesophageal junction. Above is the esophagus, a transit tube. Below, a holding tank. Surgeons cannot simply remove the diseased section gap. They must detach the stomach and pull it into the chest cavity. Traditionally, this procedure required highly invasive surgery. A modern approach is using a robotic platform that operates through 4 or 5 small incisions in the belly. Executing this complex anatomical replumbing through minimally invasive ports reduces physical trauma. Patients often bypass the ICU entirely, begin life-saving systemic therapies much sooner. Moving the stomach abdomen presents a strict biological limit. Tissue dies without blood flow. This vascular map isolates 2 major supply lines. The left gastric artery and the gastroepiploic surrounding vessels must be severed. The entire organ now relies entirely on the gastroepiploic arch, which remained intact and pulsing to keep you alive during its relocation. But detaching the stomach introduces a neurological problem. Resecting the esophagus cuts the vagus nerve. Without this nerve, the brain can no longer send signals telling the stomach to empty its contents. To counter this, surgeons perform a pyloromyotomy. They cut into the pyloric sphincter, the exit valve at the base of the stomach, permanently widening the opening. Widening this lower valve changes how the stomach operates. With the nerve signals gone, the organ relies entirely on the sheer force of gravity to ensure food continues moving into the intestines, trapped. We now look at a transparent view of the chest cavity. Surgeons enter through the right side of the chest to free the thoracic esophagus. This specific path instruments safely away from the heart and the major blood vessels grouped on the left. Once the esophagus is free, the massive physical relocation begins. The mobilized stomach slides up through the diaphragm, filling the chest cavity, and is pulled all to a small incision in the right side of the neck. With the now residing in the chest and neck, and the vagus nerves completely severed, what forces food down this new conduit? As established in the abdominal stage, gravity is now the sole engine for digestion. The widened pyloric valve ensures food drops steadily downward. This cross-section shows the final anatomical connection, osmosis. The top of the stomach is permanently sealed to the remaining cervical esophagus using 2 precise layers, an inner row of vertical mattress sutures with the knots tied on the inside, and an outer continuous layer to secure the junction. Executing action high up in the neck is a specific risk reduction strategy. It keeps the delicate suture line out of the chest cavity, avoiding the danger of a light leak near the heart and lungs. Here is a side-by-side look at the body's new anatomy. On the left, the original stomach expands as a holding tank. The surgically relocated stomach is stretched tight, acting as a rigid, narrow pipe. Because this pipe lacks holding capacity, food drops too quickly in seconds. This rapid emptying triggers dumping syndrome, leading to sudden weakness, sweating, and severe fatigue immediately after eating. This infographic outlines the first rule to manage this physical change: transition at a 30-degree angle. Because the upper esophageal valve is gone, use gravity as a mechanical shield to prevent severe reflux during the. Finally, Rule 3 dictates a strict 1-hour fasting window before guarantees the narrow conduit is completely empty before the patient lies down. Digestive tract as a mechanical system with new parameters, patients their relocated anatomy. Mastering these physical rules turns a complex.
Corrosive esophagitis is a potentially life-threatening injury that occurs when the esophagus comes into contact with powerful corrosive. Every swallow normally passes smoothly through a healthy, flexible food pipe, but a substance can destroy this delicate lining within seconds. The inner mucosal surface, and may rapidly extend into deeper layers, inflammation, tissue death, and in the most serious cases, perforation of the esophageal wall. A patient may experience sudden burning pain in the mouth, intense difficulty swallowing, excessive salivation, vomiting, and sometimes bleeding. Step by step, you watch corrosive esophagitis unfold. Chemical splash hits fast, painful, shocking, and over quickly, but doesn't end when the burning stops. Over the next weeks, the body tries to heal. In that healing, fragile surface tissue is replaced by dense scar tissue. Slowly, the esophagus tightens, narrowing into a stricture like a shrinking tunnel. Now soon, eating gets harder. They use modern endoscopy to check how narrow things have become. Then treatment can begin right away with repeated endoscopic dilatations to stretch the scar and in reconstructive surgery to restore a safe passage. The key lesson is timing. Early recognition and timely care help protect long-term swallowing. And throughout, your 3D journey helps you understand what's happening, so you know what to expect.
Acoustic injury is defined by tissue destruction resulting from chemical action. The agents responsible typically sit at the extreme ends of the pH scale, less than 3 or greater than 11, or possess high titrate. Epidemiologically, ingestions split into two demographics. In pediatrics, are accidental and involve small volumes. In adults, infrequently, allowing deep penetration. Conversely, acidic coagulation necrosis. They instantly form a hardened eschar that prevents forcing the liquid to slide downstream. The biochemical makeup of the poison predetermines the anatomical depth of the injury before the patient ever reaches the emergency room. Because the eschar protects the deeper esophageal walls, acid in false sense of security, the true damage is pushed downstream. When acid reaches the stomach, intense irritation triggers pylorospasm. The exit valve vigorously clamps shut. The trapped acid pools, causing severe, widespread necrosis of the stomach lining, while the esophagus remains intact. Fire, common in industrial and laboratory settings, defies the hydrofluoric acid. Hydrofluoric acid presents a unique molecular danger. It contains highly electronegative fluoride ions that actively seek out and bind to systemic calcium and magnesium in the patient's bloodstream. Blood of essential electrolytes, causing profound derangements that directly fatal cardiac arrhythmias. Any patient presenting with an ingestion of immediate continuous cardiac monitoring. The takes precedence over the chemical burn. A caustic ingestion is a complex event that turns the body's anatomy against itself and can trigger complete systemic collapse. In the acute phase, patients typically present with drooling and dysphagia. If a patient exhibits stridor or it indicates rapid laryngeal edema. Their airway is actively closed. In the trauma bay, the immediate priorities are rigid. Secure the airway, then initiate aggressive intravenous fluid resuscitation to counter. Clinicians avoid the instinct to purge the poison. Gastric lavage and charcoal administration are absolute contraindications. The chemical reaction and tissue destruction happen instantly upon contact. By the time the patient arrives, these interventions offer zero and only increase vomiting and re-exposure. Pushing a rigid plastic tube blindly through necrotic, melting tissue is almost guaranteed to perforate the esophagus. Diagnostic imaging must follow a strict timeline. Is required to assess the mucosal damage, but it must be performed within a narrow 24 to 48-hour window post-ingestion. If you wait past 72 hours, the damaged tissue begins to slough and becomes highly friable. Passing an endoscopy at that stage carries an unacceptably high risk of lethal than the ingestion itself. To safely map the extent of the damage on a dual modality approach, endoscopy grades the internal mucosal injury, while a CT scan looks outward, detecting hidden transmural necrosis that This 3D matrix illustrates the diagnostic pathway. Axis, we have the endoscopy findings, measured by the Zargar classification system from grade 0 to 4. On the x-axis, we map the CT transmutes. This creates three distinct clinical zones. The green zone presents low-grade injuries, classified as Zargar 0 through 2A. These patients have superficial damage. They require minimal intervention, can advance to a normal diet quickly, and are typically safe for rapid discharge. The yellow grade injuries, from Zargar 2B to 3A. The damage here is deep, putting these patients at high risk for delayed perforation and severe stricture formation. They require ICU admission, strict bowel rest, broad-spectrum antibiotics, and serial abdominal exams. Patients often consider steroids to reduce scar formation. They are generally contraindicated in this zone. Steroids inhibit fibroblast activity and delay the position of collagen. In a necrotic esophagus, this halts the necessary structural reinforcement of the wall, leaving the tissue weakened and significantly more prone to inflammation. The red zone indicates high-grade injuries, Zargar 3 to 4, or a CT grade of 4. This is massive transmural necrosis. These patients bypass observation and require immediate surgical evaluation for resection. For any adult patient, surviving the acute triage phase mandates an immediate psychiatric consultation. The mortality rate for these injuries is extremely high, and surviving a second intentional ingestion is grim. This diagnostic matrix allows clinicians to thread the needle, preventing catastrophic delayed perforations without subjecting stable patients to necessary emergency surgeries. Assuming the patient survives the chronic phase begins 3 to 8 weeks post-injury. This patient faces the consequences of the esophagus attempting to heal itself. Mucosal burns heal through extensive fibrosis. The scar tissue medical management is mechanical. Gastroenterologists use directed bougonnage or balloon dilation to physically tear and stretch the scar tissue, aiming to open the lumen to a functional diameter of at least 16 millimeters. This outlines findings from SAGES regarding severe acid-induced strictures. The data reveals that endoscopic dilation frequently fails, identifying 4 specific statistical predictors of failure. Mechanical burden, if the stricture is longer than 10 centimeters, or if the patient requires more than 6 dilations in a single year, endoscopy is likely to fail. The final 2 predictors are anatomical severity, strictures located high in the hypopharynx, or dense strictures that completely resist the passage of even an 11-millimeter dilator. Self-expanding metal stents are largely avoided in these cases. In benign esophageal disease, stents frequently migrate out of position or provoke aggressive tissue ingrowth, actively worsening the obstruction. Once a patient hits these failure metrics, medical management has lost. When the esophagus is irreversibly strictured, complex surgical reconstruction becomes the only option. The definitive surgical solution to restore swallowing is the colon interposition. Surgeons utilize the large intestine as the replacement conduit because in severe acid ingestions, the stomach is usually destroyed by pylorospasm and cannot be mobilized. During the procedure, a segment of the colon is mobilized while carefully preserving its native blood supply. It is then routed upward behind the sternum, bypassing the dead esophagus to connect directly to the healthy tissue in the neck. Restoring the ability to swallow does not end the patient's risk. The initial chemical burn casts a long shadow over their oncological future. Patients who sustain a Zargar grade 2B injury or higher face a significantly elevated risk of esophageal squamous cell carcinoma in the scarred tissue. This malignancy typically emerges 15 to 20 years post-ingestion. Because of this delay, these patients require rigorous serial endoscopic surveillance every the rest of their lives. A single caustic ingestion creates a footprint, but concludes with decades of mandatory surveillance.
If you found this video informative, please like and share, comment what you would like to see next, and subscribe to the channel to get notified about future videos.
A patient lacking barricade choking off their throat. This specific is Plummer-Vinson syndrome, or alternatively in the United Kingdom, Pattern syndrome. Both names stem from its simultaneous independent creation by American and British physicians between 1914 and 1920. The epidemiology is remarkably specific. The overwhelming majority of these patients are women over the age of 40. The diagnosis relies on a classical triad of symptoms: iron deficiency anemia, an upper esophageal web, and the resulting difficulty swallowing, known as post-cricoid dysphagia. The obstruction in the throat is the localized structural collapse caused by a systemic starvation. While autoimmune factors and genetic predispositions play contributing roles, chronic nutritional deficit, specifically in iron, healthy epithelial tissues require rapid continuous. When systemic iron is severely depleted, that turnover halts, dividing cells flatten and degrade into an atrophic layer. The earliest signs of this mucosal atrophy emerge on the periphery. The papillae on the tongue degrade, leaving a swollen, beefy red surface, a condition known as glossitis. The localized inflammation extends to the corners of the mouth, causing severe cracking identified clinically as angular cheilitis. The extremities suffer as well. The nails become brittle, aggressively thinning out until they warp into a concave, spoon-like shape termed koilonychia. These specific markers are the broader, expected signs of severe anemia, including persistent fatigue, rapid heart rate, and shortness of breath. Glossitis, cheilitis, and koilonychia are visible external warnings. The skin and tongue mirrors the structural damage silently. This glowing wireframe maps the human esophagus. To locate the physical obstruction of Plummer-Vinson syndrome, we have to look exclusively at the upper cervical region, isolating the area around the cricopharyngeus muscle. Here, chronic mucosal atrophy triggers a subepithelial fibrosis. The resulting web is thin and gray, entirely in normal-appearing mucosa. From a cross-sectional view, it forms an eccentric hole, typically with a central or lateral opening. The resulting dysphagia is aggressive but painless. Patients typically only begin to notice symptoms when abdominal diameter shrinks past a critical mechanical threshold, 12 millimeters. Obstructions that occur further down the digestive tract represent entire pathological mechanisms. A Schatzki ring, for example, forms in the lower esophagus, strictly at the squamo-columnar junction. Unlike upper esophageal webs, this lower ring involves the submucosal layer. It is not driven by an iron deficit, but is the mechanical threshold for symptoms also differs. Schatzki rings begin to trigger dysphagia drops below 15 millimeters. Anatomical location and boundaries dictate the etiology. Upper webs are the result of nutritional failure, while lower rings point to biomechanical stress at the junction. Because the structural defect is rooted in a nutritional deficit, clinical suspicion requires hematologic action. Physicians start by drawing a complete blood count and a peripheral smear, followed by a comprehensive iron panel, measuring serum iron, ferritin binding capacity. Once cytopenia is confirmed on paper, physicians deploy dynamic radiological imaging to physically map the stricture. In a barium swallow simulation, the radiopaque liquid cascades down the holes against the shelf-like indentation. Barium esophagograms provide an initial accurate map of the web's exact location and severity. The gold standard diagnostic step, however, requires directly entering the airway with an esophago-gastroduodenoscopy, or EGD. Endoscopy is the safest. It positions the physician to perform immediate intervention. A definitive diagnosis bridges hematology and endoscopy, verifying the invisible chemical deficit in the blood and mapping the first-line intervention targets the root cause. Aggressive supplementation with 150 to 200 milligrams of elemental iron will induce advanced, heavily fibrous action. Physicians must instead apply direct mechanical force, endoscopic balloon dilation, the forceful path of Savary-Gilliard bougies, or a precise needle knife electroincision, breaking the barricade and not clear the patient of long-term danger. This assessment chart illustrates the long-term threat. The chronic cellular dysplasia, initially driven by the iron deficiency, leaves behind a highly volatile environment. Between 3 and 15% of people with this syndrome will eventually develop squamous cell carcinoma of the oral cavity, the hypopharynx, or the upper esophagus. Plummer-Vinson syndrome, temporary physical barricade in the throat, is an warning of a cellular instability that demands rigorous, lifelong clinical. This is the esophagus. A rapid descent down this healthy tract brings us to a dead stop at the muscular sphincter of the esophago. It is a linear laceration of the mucosal layer. This pathology does not stem from a creeping infection or a slow chemical erosion. It is the result of sudden, overwhelming mechanical force. Albeit extreme physiological reflex, rapidly overloads the local tissue architecture, resulting in acute structural damage. To manage this, we must trace the physical vectors, navigate a diagnostic trap, and escalate to surgical repair. Understanding the exact pressure dynamics that tear is necessary to predict the resulting clinical complications. The severity of this mechanical tear dictates every subsequent decision algorithm. Effectively managing Mallory-Weiss syndrome requires the clinician to treat the physics of the gut rather than simply reacting to the resulting hemorrhage. The injury begins with the physical mechanics of vomiting across both the thorax and the abdomen. During reflex, a critical superior boundary is formed as the glottis closes tightly, sealing off the airway. Simultaneously, an inferior boundary is created by the sudden, violent contraction of the abdominal musculature. The abdominal muscles contract, we see a massive exponential spike in intra-abdominal pressure, building between these two closed boundaries. Unable to expand downward, this trapped pressure gradient transmits directly upward into the esophagus, taking any available point of release. The stress vectors concentrate forcefully at the anatomical bottleneck of the esophagogastric junction. The exact moment of occurs when this surging pressure exceeds the tensile strength of the local tissue, ripping a linear laceration directly through the mucosa layer. When this upward is more extreme, the same basic mechanism can cause Bohov syndrome, demonstrating the wider spectrum of mechanical trauma. While Bohov results in a spontaneous, full-thickness transmural rupture of the muscularis, a partial thickness tear confined to the mucosa. The closed glottis essentially acts as an anvil. The contracting abdominal muscles drive the esophageal mucosa against this sealed resistance, forcing the tissue to split. In the immediate aftermath of this tissue failure, the clinical picture shifts from physics to hemolymph and venous blood, slowly pools downward into the stomach cavity. Is then followed by a secondary event that forces them to see emesis, vomiting blood, or melena, passing dark, tarry stools. Precise temporal relationship is mandatory for a Mallory-Weiss diagnosis. Forceful, non-bloody emesis must occur prior to the hemorrhage. A patient who vomits blood immediately on their first episode, without a prior history of non-bloody retching, is likely suffering from a completely different pathology, such as ruptured esophageal varices. If the pool sequence of symptoms is the primary clinical indicator, a disrupted timeline should immediately point the investigation away.
To confirm the diagnosis, esophagoscopy is considered the optimal tool for directly visualizing mucosal tears. However, there is a severe practical limitation. In a majority of acute cases, profuse hemorrhage physically obscures the optical lens of the endoscope. This creates a diagnostic paradox. The most threatening cases generate so much blood volume that they render the best optical diagnostic tool completely useless. This split-screen schematic illustrates the necessary clinical pivot. On the left, the endoscope's conical field of view is entirely blocked by liquid volume. On the right, a celiac angiogram map bypasses the optical obstruction, isolating the active bleeding vessel with high contrast. By mapping the vascular flow directly to the lesion, angiography identifies of the tear, even when the internal bleeding is profound. Its only utility in this scenario is ruling out other structural anomalies, differential diagnosis. Wasting time on barium study failed endoscopies while a patient is actively hemorrhaging is incredulous. The raw severity of the hemorrhage must dictate the diagnostic, forcing a rapid, calculated shift from optical source evaluation to vascular imaging. Once the bleeding site is identified, the first-line management protocol focuses strictly on conservative hemodynamic stability. The immediate clinical orders are clear. Nothing is allowed by mouth, and continuous nasogastric aspiration is started to clear the stomach. Intravenous blood transfusions are initiated simultaneously to replace lost volume and counter impending hypovolemia. Adjunctively, localized iced saline gastric lavage may be performed to induce vasoconstriction and encourage natural hemostasis. In the vast majority of cases, this strict conservative approach is highly successful at halting the hemorrhage. However, there is a clear threshold for escalation. If the bleeding remains continuous or becomes profuse in spite of these stabilizing, surgical intervention is required. The operation of choice is a long proximal gastrotomy. This specific incision provides the direct mechanical access necessary
evacuate the obstructive blood clots from the stomach, and physically expose the esophagogastric junction for inspection. The surgical solution is direct and absolute. The surgeon manually oversews the mucosal tear, securely binding the tissue to permanently halt the vascular leak. The entire algorithm is a calculated escalation. It begins by providing the body with passive physiological stabilization, and when that fails, it culminates in aggressive mechanical closure. Mallory White direct consequence of mechanical physics. It is the result of extreme trapped pressure gradients causing localized structural failure at the junction of the stomach and esophagus. Diagnosing it requires recognizing a specific timeline of symptoms and avoiding the trap of relying solely on optical endoscopy when the lens. For those patients who cross the threshold into surgical intervention, the prognostic outlook is exceptionally strong. Once the mucosal layer is successfully oversewn, the risk of recurrence drops to near zero. As we pull back from this perfectly healed, sutured mucosal layer, the ultimate clinical lesson is now clear. Mastering this condition requires understanding the biomechanics of the initial injury just as thoroughly as the surgical mechanics used.
If you found this video informative, please like and share, comment what you would like to see next, and subscribe to the channel to get notified about future informative videos. Please like and share, comment what you would like to see next, to get notified about future
The pharynx to the face, timed contractions while maintaining structural integrity. This 3D illustrates the normal esophageal architecture. The wall is built of 4 distinct layers: the inner mucosal lining, the submucosa, the muscularis, which provides the propulsive force, and the outer adventitia. In a healthy state, allowing food to pass into the stomach. Medical failure of this system generally falls into one of 2 categories. The first, where the esophagus experiences a loss of propulsive force, resulting in dynamic, stagnant flow. The second mechanism is localized, resulting in anatomical anomalies. On the left is a true blowout, where all esophageal wall are stretched outward. On the right is a false blowout, where the pressure forces only the mucosa and submucosa to herniate through a gap in the muscle layer. Effective intervention requires mapping the pathology back to its specific anatomical layer of failure. Scleroderma is an autoimmune collagen vascular disease. The primary mechanism of this disease is the destructive replacement of healthy smooth muscle tissue with rigid fibrous. It is flat-lined and adynamic to its peristaltic capability. Looking at the lower esophageal tracing, we see the secondary consequence. The LE its baseline tone, causing it to gape open. This creates a destructive. Without the protective barrier of the LES or the clearance capability of peristaltic, acid refluxes upward into the unprotected esophagus, chronic mucosa, causing reflux esophagitis. Patients present with a triad of symptoms: severe heart acid, progressive dysphagia as the stricture tightens, and subsequent regurgitation. Confirming this diagnosis requires a specific workflow: a barium swallow to visualize the resultant dilatation and strictures, manometry to confirm the adynamic smooth muscle, and pH monitoring to quantify the acid exposure. First-line medical management focuses on utilizing proton pump inhibitors and H2 blockers like cimetidine or ranitidine to halt the chemical burns. If persistent strictures form despite medical therapy, surgery is the fallback. The standard approach is a callus astroplasty to lengthen the functional esophagus, combined with a Nissen fundoplication to recreate the lost tone. Scleroderma forces clinicians to manage an irreversibly hypocontractile system. The goal is to salvage structural integrity and prevent further acid damage. If systemic failure is characterized by a lack of muscle contraction, pressure failures represent the opposite. The model illustrates the anatomy of the upper sphincter. Superiorly, we have the oblique fibers of the thyropharyngeus. Below it sits the cricopharyngeus muscle, which is oriented. Of these 2 muscle orientations creates a natural anatomical weak point known as Killian's dehiscence. The mechanical out here is functional. During a swallow, if the cricopharyngeus muscle or fails to relax, it creates an obstruction. The pharynx continues pushing food down against this closed sphincter. This discoordination causes a spike in intraluminal pressure, forcing the inner tissues to blow out through the weak spot. angle. This histological cross-section details the result. Zenker's diverticulum. Because only the mucosa and submucosa herniate through the gap, leaving the muscularis layer behind, it is classified as a false or Pulsion.
This pathology has a distinct demographic, occurring most frequently in older males, typically over the age of 60. The first major clinical symptom is severe halitosis. Undigested food becomes physically trapped inside the rot. The most dangerous complication occurs when the patient lies flat. The trapped food regurgitates from the pouch and spills into the airway, required for a Zenker's diagnosis. This same mechanism occurs at the opposite end, resulting in an epiphrenic diverticulum. This anatomical map plots the locations. While Zenker's occurs proximally in the neck, epiphrenic diverticula share the same false Pulsion-based mechanism, but occur the distal 10 centimeters of the esophagus, just above the diaphragm. Because they sit so low, epiphrenic diverticula are associated with underlying disorders like achalasia and GERD. Evaluating them requires manometry to identify the root distal tissue, structural consequences of localized pressure gradients. In the mid-esophagus, specifically the parabronchial region near the tracheal bifurcation, the mechanics change. Here, we see the mechanism of external tethering. Inflamed granulomatous mediastinal lymph nodes physically adhere to the outside of the esophageal histoplasmosis. As the inflamed nodes heal and fibrose, they shrink. This creates a traction effect, pulling all 4 layers of the esophageal wall outward to create a tent-like true diverticulum. Clinically, the are largely asymptomatic. Management focuses on treating the underlying infection. Surgery is only indicated if tissue necrosis forms a direct fistula into the respiratory tract. The biomechanical failure here is how to definitively fix a localized pressure blowout. The foundational surgical rule for Pulsion diverticula is that the pouch is a symptom. Simply removing it leads to recurrence. The surgeon must divide the restrictive hypercontractile muscle itself, a procedure known as a myotomy. The traditional approach for a Zenker's pouch required an external cervical incision through the neck, performing the cricopharyngeal myotomy. Early minimally invasive surgery utilized a flexible dividing septum, a technique known as the Dolman procedure. The schematic illustrates the modern standard in third space endoscopy, Z-POEM, or Zenker's peroral endoscopic myotomy. The endoscope create a submucosal lift, then burrows beneath the mucosal tunnel. The surgeon meticulously divides the cricopharyngeus muscle, leaving the overlying mucosal layer intact. This creates a complete myotomy to relieve the pressure, while the mucosal barrier is secured with clips to prevent retropharyngeal leaks. This same poem philosophy is applied distally to epiphrenic diverticula, dividing the lower muscles to resolve the outflow obstruction. Modern surgery targets the root functional cause, the hypercontractile muscle, from within the lumen, preserving the esophageal anatomical integrity. Looking at etiologies, the systemic collagen deposition. Zenker and epiphrenic are focal pressure failures resulting in false diverticula. Diverticula result from external tethering, creating a 4-layer true system. Scleroderma requires medical acid suppression, hypocontractility. Zenkers and epiphrenic diverticula require myotomies to relieve the focal hypercontractility. Mid-esophageal traction diverticula require conservative medical management aimed at the underlying granulomatous infection. Definitive management of esophageal disease rests on pinpointing the specific mechanical failure, be it systemic atrophy, localized hypertrophy, or external tethering.
If you found this video informative, please like and share, comment what you would like to see next, the channel to get notified about future informative videos.
Healthy esophagus, alsis pushing a swallowed bolus down. Now the scene flips to diffuse esophageal spasm, corkscrew esophagus. Powerful waves shown as the food pausing, then crisscrossing through the spasm. Look closer at the esophageal wall. Tiny nerve signals like scrambled instructions to the muscle. When coordination breaks, contractions become uncoordinated and overly strong, creating the classic corkscrew look. You may also notice the mid and lower segments squeeze tight feel unpredictable, even when you're trying to stay calm every time. Diffuse esophageal
Diffuse esophageal spasm, or DES, is a rare primary motility disorder. Instead of moving coordinated wave, the esophagus suddenly shatters into chaotic, uncoordinated contractions. Normal primary peristalsis relies on a precise sequential balance. Excitatory nerves signal the muscle above the food bolus to squeeze, while inhibitory nerves signal the muscle below to relax and clear the path. This animated cross-section of the esophageal wall shows the root of the pathology. In DES, the myenteric plexus, work governing the esophagus, idiopathically fails to deliver its inhibitory stop signals. The excitatory nodes, however, continue to fire simultaneously. Deprived of those crucial relaxation cues, the circular muscle undergoes multiphasic, repetitive, and premature contractions. Entire segments of the esophagus clamp down tightly at the exact same time. When multiple isolated segments contract simultaneously, the macroscopic morphology of the esophagus changes entirely. The smooth tube distorts into a distinct spiral, characteristic corkscrew silhouette. Clinicians cannot rely on looking for anatomical hardware defects to spot this condition. DES is a physiological software problem, a severe case of faulty neural wiring. This neuromuscular failure presents more frequently in the female demographic. Patients presenting with DES also have high clinical overlap with other functional gastrointestinal disorders. A detailed patient history often reveals existing diagnoses of irritable bowel syndrome, spastic colon, or pylorospasm. Spasming events require an initiation cue. Common physical triggers are fluids at temperature seemingly peak during periods of acute emotional stress. Once the trigger esophageal motility may completely return to its normal baseline. Episodic, trigger-dependent nature of the disease severely complicates the diagnostic pathway. A patient's esophagus may appear structurally and functionally perfect during a standard clinician, hiding the underlying pathology. The clinical presentation is sudden, severe, colicky chest and outlines the referred pain pathways for a spastic event. Typically anchors under the lower half of the sternum and heavily radiates outward, extend the back, up to the shoulders, and down the arms. The secondary presentation is dysphagia, or difficulty swallowing. The intense chest pain reflux is a distinctly separate issue. True regurgitation is rare, though highly observant patients may report regurgitating saliva during the colic episode. The intense radiating pain creates an immediate diagnostic hazard. This symptom profile perfectly mimics angina pectoris or an active myocardial infarction. Therefore, the mandatory first step of the diagnostic pathway has nothing to do with the esophagus. An ECG must be performed immediately to exclude coronary artery disease. Severe, non-cardiac chest pain must be treated as a cardiac emergency until clinical data proves otherwise. Only when the heart is cleared do esophageal investigations become the clinical priority. Step clears or eosinophilic esophagitis. Because DES is a functional timing failure rather than specifically the barium swallow X-ray, radiograph shows the textbook findings of the disease. The segmental contractions heavily distort the barium flow, leaving this stark, curled corkscrew appearance. The radiograph may also highlight secondary, associated anomalies. Clinicians might observe a distal beak-like taper or esophageal pulsion diverticula caused by the extreme internal pressure. There is a major diagnostic gap here. The barium corkscrew abnormality in less than 50% of cases.
Relying solely on structural imaging will cause the clinician to miss the majority of DES. The absolute gold standard for diagnosing a motility disorder is high-res ometry, or HRM. Instead of looking at physical structure, HRM measures physiological pressure and wave coordination in real time. This is a resolution manometry topography plot mapping the patient's swallows. To achieve a diagnosis under the Chicago classification criteria, the data must show premature swallows occurring in at least 20% of the tests. We define a premature during the timing of the wave. The plot must show a distal latency of less than 4.5 seconds in the esophageal body. We then look at the esophagogastric junction, or EGJ. In DES, the integrated relaxation pressure remains normal.
This specific metric clearly differentiates DES from achalasia, where the valve fails to open. We must also differentiate DES from hypercontractile esophagus. We compare the raw force output. Hypercontractile esophagus produces a massive wave with a distal contractile integral over 8,000. DES maintains normal force. The failure is entirely in the timing. Before confirming the diagnosis, meticulously review the patient's medication history. Opioid-induced esophageal dysmotility generates an identical manometry plot and must be ruled out. High-resolution manometry is the only modality capable of definitively categorizing esophageal dysmotility. Once diagnosed, the core management acts is simple. Clinicians must treat the patient's dominant symptom, not the numbers on the manometry plot. If the clinical presentation is heavily dominated by dysphagia symptoms, the treatment pathway focuses on releasing the muscle tension. The endoscopic view illustrates smooth muscle relaxants binding to receptors on the tense muscle fibers, forcing the tissue to elongate and relax. Administering sublingual nitroglycerin or calcium channel blockers resolves the premature squeeze. Peppermint oil is an effective supplementary option, offering a simple, well-tolerated method to aid in relaxing the smooth muscle. If the clinical presentation is dominated by non-cardiac chest pain, the treatment shifts entirely. Muscle relaxants are not the primary tool here, driven by visceral hypersensitivity. The nervous system acts as an amplifier, escalating the sensory feedback into debilitating pain. To treat the pain, prescribe low-dose tricyclic antidepressants. They function as neuromodulators, actively dampening the overactive sensory pathways and turning down the volume of the pain signals. At the mechanical squeeze, or at the neurosensory feedback loop. For refractory, where pharmacological therapy fails to provide relief, the call escalates to physical intervention. The first tier of invasive options offers temporary mechanical disruption. Clinicians can inject botulinum toxin endoscopically to paralyze the hyperactive muscle to force the esophagus open. This details the definitive surgical intervention, the long esophagomyotomy. The surgeon begins at the lower sphincter, carrying the longitudinal incision exceptionally high, extending all the way up to the aortic arch. Clinicians must manage surgical expectations. Esophagomyotomy for DES achieves in 75 to 80% of patients, making it less uniformly successful than identical procedures performed for achalasia. If the patient also presents associated hiatus hernia, the surgical parameters dictate that an anti-reflux operation must be performed concurrently with the myotomy. Finally, clinicians must recognize that a small, highly significant percentage of DES patients will evolve. Over time, their spastic motility disorder will progress into full-blown. Spastic disorders do not remain static. Long-term clinical follow-up because a diagnosis of diffuse esophageal spasm today may simply stop on a longer pathophysiological journey.
If you found this video informative, please like and share, comment what you would like to see next, and subscribe to the channel about future informative videos.
Achalasia is an incurable neuromuscular disorder defined by a specific dual failure within the esophagus. The first failure occurs here. The coordinated peristaltic waves are completely absent. The second failure occurs at the base. In response to a swallow, the lower esophageal sphincter remains clamped and fails to relax. The underlying neural pathways that cause this uncoupling cannot be repaired. Result, pharmacologics of this failure, reduction of distal resistance to restore gravity-dependent flow. Managing the condition requires the physical destruction of the sphincter's resting tone. The underlying neurological function cannot be recovered. To visualize the consequences of that closed lower esophageal sphincter, clinicians start with a barium esophagogram. As the disease progresses, the initial imaging shows slight dilation. Over time, this expands into a massive, reveals the macroscopic hallmark of achalasia. The fluid tapers down into a sharp, unyielding bird beak shape. In a lateral X-ray, this retention creates a distinct posterior mediastinal air fluid level, and below the diaphragm reveals a complete absence of normal fundal gas. These late-stage structures are highly recognizable. Bariums reveal the macrostructural results of the blockage. They do not quantify the specific muscular failure causing it. The gold standard diagnostic tool for achalasia is esophageal manometry. This multi-channel graph maps internal pressure. The baseline. When a swallow triggers, chaotic, low-amplitude spikes replace normal peristalsis. The upper sphincter functions correctly, dropping pressure normally. However, the lower sphincter displays signs completely flat and unyielding. To confirm the specific denervation hypersensitive esophageal pressure, followed by cutaneous contractions. This sudden manometric pressure spike correlates directly with the patient's acute presentation of severe chest pain. Manometry. Any endoscopy is mandatory to rule out pseudoachalasia, which is often caused by a carcinoma blocking the cardia. Endoscopy allows clinicians to directly assess the extent of mucosal damage, navigating down the esophagus to determine the specific type of esophagitis present. This panel shows reflux esophagus, whitish and fibrotic, marked with The right panel completes the comparison, showing retention esophagitis specific to achalasia. The mucosa is highly edematous, characterized by a distinct discoloration. This edematous, purpuric inflammatory response is the direct result of undigested food and saliva chronically pooling against the closed sphincter. Visually confirming retention esophagitis underscores the urgent clinical to drain the esophageal column. Because the underlying cause remains uncorrected, clinicians focus on the direct physical disruption of the distal obstruction. Treatments like sublingual nifedipine and calcium channel antagonists offer only transient relief. Endoscopic injection of botulinum toxin directly in the esophageal sphincter offers a chemical alternative. The toxin acts by interfering with the cholinergic excitatory neural activity at the sphincter, chemically forcing it to relax. But the muscular paralysis from Botox is temporary. It requires repeated injections after several months, leaving its definitive role unestablished. Mechanical dilation. A 30 to 40 millimeter plastic balloon is routed over a guide wire. As it inflates within the cardia, the circular muscle fibers. This mechanical tearing yields curative symptom relief in 75 to 85% of cases, particularly in patients over 45. For cases requiring an alternative, Heller's myotomy direct surgical approach, physically sectioning the muscle fibers with a scalpel. Whether by chemical denervation, pneumatic tearing, or surgical scalpel, the objective destruction of baseline sphincter tone. Achalated nerve control in the esophageal body cannot be reversed. This split illustrates the clinical objective. On the left, the elevated high-pressure reading blocks the bolus at the cardia. On the right, the post-dilation model demonstrates zero resting pressure at the sphincter. The widened cardia allows gravity to easily clear the bolus. Successful management of achalasia relies entirely has permanently failed. Imagine a meal. Strangely, eating a solid piece of bread feels sip from a glass of cold water feels impossible. The liquid just stops in your chest, refusing to go down. Later that night, that same food effortlessly flows right back up in the mouth. But there's a strange detail here. It doesn't taste sour or acidic like normal vomit. Physicians have documented these before, but it was in 2015 that Dr. Arthur Hurst gave the condition its modern name, achalasia. In Greek, it means failure of relaxation. This specific combination of symptoms points to a breakdown in the mechanical reflex of the esophagus, system that normally ensures food moves in only one direction. In this patient's chest X-ray, notice the central lower region. Something is completely missing. Normally, a distinct translucent pocket of gas sits at the top of the stomach. In achalasia patients, that gas bubble is completely absent, so we have food that comes back up tasting normal, and a stomach strangely empty of air. Something is physically blocking the stomach. Normally, it opens to let food pass. In this condition, it remains tightly clenched during a swallow, acting as a physical wall. But the muscle itself isn't broken. The defect is neurological. The esophagus is lined with a network of nerves called air. Researchers have tracked this nerve death back to a variety of external triggers. It can be initiated by severe emotional stress, physical trauma to the chest, or systemic infections. In some parts of the world, the damage is caused by Chagas disease, seen here among red blood cells. Crescent-shaped parasite Trypanosoma cruzi directly attacks the stomach, the closed position. A highly active transit tube is reduced in a trap. This paralyzed valve explains our missing gas bubble. When a person swallows a bolus of food, a small amount of air naturally it. Because the food is stopped abruptly at the sphincter, the accompanying air makes it into the stomach cavity. It also explains why regurgitated food doesn't taste sour. The food is pooled just below the valve. And early on in the disease, solids actually pass more easily than liquids. The esophagus has lost its normal pumping action, so it relies entirely on gravity. A dense piece of food has the physical mass and weight to push its way through the tight valve, while a liquid lacks the mass to force it open. What once seemed like a collection of strange, unrelated occurrences is actually the logical byproduct. The backed up food and fluid cause severe chest pain, but eventually, for many patients, that pain vanishes completely. This vanishing pain is deceptive. The esophagus hasn't healed. Instead, the continuous pressure of trapped food has stretched the tissue to its breaking point. It permanently dilates, ballooning outward into a sagging, distorted known as a mega-esophagus. Doctors have to perform tests to rule out pseudoachalasia, where a very similar blockage is caused by physically compressing the lower esophagus rather than internal nerve. But in true achalasia, the sudden end to the chest pain is a false flag. It marks the exact moment of permanent anatomical deformation. Once the esophagus dilates to this extreme size, it begins holding pounds of trapped, fermenting food residue. This constant irritation triggers chronic inflammation called retention esophagitis. Inability to eat properly leads to dangerous weight loss. The physical danger peaks at night. When the patient lies flat to sleep, for a timeline of years, the mucosal lining takes a toll. Patients face a 5 to 10 developing squamous cell carcinoma, a type of cancer that tends to arise right in the middle third of the swollen organ. It exposes the extreme fragility of our internal plumbing.
The death of just a handful of microscopic nerve cells is enough to irreversibly break the physical mechanics of swallowing, turning a biological pathway into a severe systemic threat.
If you found this video informative, please like and share, comment what you would like to see next, and subscribe to the channel to get notified about future informative videos.
Of the abdomen. This diagram details of the esophageal hiatus, where notice how the diaphragm firmly esophageal sphincter, which sits securely at this anatomical pinch point. The intersection is vulnerable to mechanical failure. When the strict hiatus breaks down, structures from below can. This is a hiatus hernia. Specifically, it involves the herniation of the stomach widened hiatus and directly into the thoracic cavity. Moving the stomach into the chest alters the pressure dynamics of the entire gastroesophageal junction, categorized by exactly how the anatomy displaces through the defect. Pinning the exact mechanics of the protrusion is the required first step for an accurate clinical diagnosis and effective treatment. The clinical classification system divides hiatus hernias into 3 distinct types based on their structural presentation. The gastroesophageal remains anchored in the abdomen, but the gastric fundus rolls up through the hiatus. Type 3 is the mixed type. It combines both mechanics, with the junction and the fundus hernia. Then we have type 1, the sliding or axial hiatus hernia. Type 1 dominates the clinical landscape, accounting for more than 80%. Mastering the intricate pathology of the gastroesophageal junction means deeply studying specific mechanics of the type 1 sliding defect. Strictly speaking, the type 1 sliding variant defies the standard definition of a hernia. First, it does not produce a typical hernial sac. Second, and more importantly, the unique status of the phrenoesophageal membrane. As this membrane stretches significantly, but it remains, it slides directly upward into the thorax. Looking at the right side of our diagram, the mechanics of this sliding displacement become clear. The directional arrows show the esophageal junction forced entirely into the chest cavity. This axial shift pulls the lower esophageal sphincter out of its normal position, compromising its competency. Without the structural support of the diaphragm, the sphincter loses the physical pinch it relies on to prevent retrograde flow. Because the anatomy freely slides, the stomach may spontaneously requires a diagnostic approach that Visualizing an anatomical defect that slides back and forth presents a specific challenge. The gold standard initial indication is the barium meal X-ray, a contrast radiographic study. Barium meal X-ray demonstrating a confirmed type 1 sliding hernia. One of the diaphragm sits lower in the image, while the bright white barium is in the patient into a semi-prone position on their right side. Next, the examination table is tilted head down into a strict 20-degree Trendelenburg position. In this orientation, gravity forces the barium to regurgitate and fill the potential hernial. This regurgitation must occur on its own, without the aid of any. Once the structural defect is definitively confirmed radiographically, clinicians then turn to a direct internal assessment using an endoscope. This endoscopic photograph provides direct visual evidence of the failure. The black tube in the center is the retroflexed endoscope, looking back up at itself. Surrounding it are the loose, abnormal gastric folds of the herniated stomach, completely failing to tightly grip the instrument. Beyond verifying the structure, the endoscopy serves a critical secondary purpose: the esophageal mucosa for varying degrees of esophagitis caused by reflux. Combining the dynamic structural proof of the barium swallow with the mucosal assessment of the endoscopy yields a complete clinical picture of the defect. Despite a profound upward displacement of the stomach, a sliding hiatus hernia can often be symptomless. The clinical baseline is clear. If the defect produces no symptoms and barium does not regurgitate spontaneously, no treatment is required. This acidic reflux dictates the resulting clinical presentation, regurgitation, and dysphagia. Therefore, the treatment of a symptomatic type 1 hiatus hernia is identical to the treatment of gastroesophageal reflux disease. While extensive herniations might eventually require a keyhole or robot-assisted surgical repair, the frontline approach relies on pharmacological management of the acid reflux itself. The presence of a sliding hernia.
Hiatal hernias are highly common, but they are not a single uniform disease. Roughly 90% of all cases are classified as type 1, or sliding hernias. Because their symptoms are typically limited to acid reflux, they are routinely managed with basic medical treatment and lifestyle modifications. But the remaining 10% of different clinical scenario. This is the type 2 paraesophageal or rolling hernia. Look at these barium swallow radiographs. On the left, a sliding hernia shows a small stomach portion slipping evenly above the diaphragm. In the center type 2 image, a massive section of stomach has migrated completely above the diaphragmatic line into the chest. This structural difference, like hiatus, dictates an entirely divergent clinical path for the patient. Severe anatomical displacement, a type 2 hernia often presents without any symptoms at all. It is easy to assume that if a patient feels it is a true hernia. It features a dedicated hernial sac, which allows the stomach to silently and continuously expand into the chest over time. Silent growth hides a physical vulnerability inside the thorax, a potential dilation that can trigger without warning. This risk changes the treatment goals. While a type 1 hernia is managed based on the patient's symptoms, a type 2 hernia is managed based on its anatomical potential for sudden complication. To understand why this happens, we have to look at the anatomy of the diaphragmatic hiatus, the position below the diaphragm. Because the act below the diaphragm, patients rarely experience the classic acid reflux associated with hiatal hernias. Instead, the fundus of the stomach physically rolls up through the left anterolateral portion of the hiatus, squeezing upward alongside the esophagus. The anchored esophagogastric junction masks the severity of the disease, which will reveal an abnormal air fluid level in the mediastinum right behind the heart. To confirm the diagnosis, clinicians use a barium swallow. Looking at the central panel of this barium swallow, our primary objective is pinpointing the esophagogastric junction. The blue arrow points to the junction safely anchored below the diaphragm, while the yellow arrow highlights the massive stomach trapped above it. Once identified, we must rule out hyperoptic gastroesophagoscopy to inspect the internal lining directly. Radiographically mapping the junction's location is the dividing line between a case requiring medical management and one demanding surgery. Inside the chest, the herniated gastric pouch continues expanding upward, taking up space in the thorax and physically pressing against the outside of the distal esophagus.
The sheer mass of the stomach creates intense of digestive disturbances, fullness after small meals, feelings of early satiety, and difficulty swallowing. Because the stomach is trapped out of its normal position, fluid and partially digested food begin to experience severe stasis inside the This chronic stasis causes trapped gastric acid to erode the mucosa of the stomach wall. Returning to the radiograph flux allows the hernia to quietly grow large enough to cause severe structural and mucosal decay, long before the patient realizes something. These specific hernias can achieve massive proportions inside, but the entry point at the diaphragmatic hiatus remains a dangerous pinch point that incarcerates the stomach tissue. The trapped air and fluid inflamed riding ulcer faces an immediate risk of perforating directly into the chest, slowly turning a benignly expanding pouch into a pressurized incarceration. The ultimate fatal risk of a type 2 hernia is gastric vulvar. The stomach is highly mobile. It can physically twist on its axis, creating a complete mechanical obstruction. This strangulation rapidly cuts off the blood supply, leading to acute tissue necrosis, and if uncorrected, sudden death. A sliding hernia is typically a chronic condition defined by acid. A volvulus is an acute surgical emergency. The expansive mobility of the herniated stomach transforms a simple anatomical tear into a lethal emergency, proving exactly why clinical type 2 indication for surgery. While an abdominal approach is possible, the majority of surgeons prefer a thoracic approach, as the large herniated mass is often heavily adhered to surrounding structures deep in the mediastinum. The surgical repair relies on 4 strict principles. First, the hernia is reduced. Second, the hernial sac is eliminated. Third, the massive opening in the hiatus is repaired. Flux procedure secures the junction. Even with a successful repair, patients face a long-term risk. The sheer size of the original mass severely attenuates diaphragm muscles. While structurally complex to repair, Let's look at the gastroesophageal junction. When the lower esophageal sphincter weakens, it creates a mechanical failure upward into the esophagus, causing reflux. To fix, surgeons don't implant synthetic parts. Instead, they use the patient's own stomach tissue to engineer a replacement valve. The procedure usually begins laparoscopically. Surgeons insert 5 cannulae into the upper abdomen, above the umbilicus, and separate the lower esophagus from the diaphragmatic hiatus to expose the workspace. Before the top section of the stomach, so it can be manipulated. This model demonstrates the classic Nissen function. The fundus is drawn behind the esophagus, pulled around to the front suture to create a complete 360-degree collar. In a toupee procedure transition, the fundus is sutured only laterally, leaving the anterior aspect exposed. Both of these wraps require natural length and slack. The newly constructed valve sits comfortably within the abdomen without tension. When acid reflux goes untreated for years, the damage moves past gross mechanics, altering the tissue itself. In this microscopic cross-section, flat squamous are eroded by acid. As a defense, the places them within migrates beyond the stomach junction, sometimes reaching the aortic arch. This cellular shift is known as Barrett's esophagus, and it carries specific clinics. The columnar tissue can undergo dysplasia, elevating the threat of adenocarcinoma. Because of this, surgeons must defend against immediate acid erosion, but it makes a dangerous biological trait, creating an environment that carries a long-term risk of cancer. The pathology of Barrett's often involves chronic inflammation and ulceration. As this inflamed tissue scars at the junction of the squamous and columnar cells, it forms thick, rigid strictures. This vector diagram illustrates the main biomechanical consequence of that scarring. A stricture doesn't merely narrow the passageway, it contracts vertically. The entire esophageal tube is physically shortened and pulled tautly up. The required medical baseline to combat this involves aggressive therapy and dilatations. Physicians carefully widen the passage until a number 40 French bougie fully clear the stricture, significantly reducing edema and spasm. Pause and consider the geometry. How can a surgeon possibly use the stomach to wrap around it? That structural shortening breaks the primary rule for a standard Nissen repair, forcing the surgeon to artificially lengthen the operative field. If the natural esophagus is too short, the surgical solution is the collis gastroplasty. The surgeon sacrifices the upper portion of the stomach to build a new esophageal extension. In this graphic, we see a rigid bougie pushed down through the shortened esophagus, extending straight into the upper stomach cavity. This tool serves as an internal sizing mold. The surgeon makes a longitudinal incision straight down the upper stomach tissue, running parallel to that internal bougie. The tissue on the lesser curvature side of the cut is sutured tightly around the mold. This transforms a section of the stomach, elongated neo-esophagus, extending the tube straight down into the abdomen. Now that adequate length is restored, the remaining outer flap of the divided stomach, the redundant fundus, is wrapped completely around this new tube to form a secure anti-reflux valve. When chronic inflammation destroys natural anatomy, precise surgical geometry allows us to repurpose existing tissue and restore mechanical function. This 3-panel infographic maps out the progression. In panel 1, normal anatomy with adequate esophageal length easily accommodates a standard 360 degrees. When unchecked reflux triggers cellular changes, the body Barrett's esophagus, and the subsequent strictures physically shorten the operative field. The operative rule first, and deploy a collis gastroplasty to reconstruct the tube when strictures compromise.
Dysphagia is a disorder in which the lower esophageal sphincter is to relax, preventing food from entering the stomach. As food accumulates, the esophageal dilates, causing dysphagia, regurgitation, chest discomfort, and weight loss. The fundoplication. After induction of general anesthesia, the patient is positioned in a reverse Trendelenburg position. Small laparoscopic ports are inserted into the upper abdomen. The left lobe of the liver is gently elevated, hiatus, and the gastroesophageal junction, where the operation begins. The phrenoesophageal membrane is carefully divided to enter the hiatus. The lower esophagus is gently mobilized within the mediastinum, while preserving both the anterior and posterior vagus nerves. Fibrous attachments surrounding the circumferent stomach. The muscular layers of the esophagus are now clearly identified. Longitudinal muscle fibers are separated, revealing the underlying circular muscle that forms the abnormally tight lower esophageal sphincter, responsible for the patient's symptoms. The Heller's myotomy now begins. The circular muscle fibers are divided with meticulous precision, while the delicate mucosa beneath is preserved intact. The muscle
they're the primary mechanism for normal, everyday health reflex. Then along comes another pioneer, Deciphering, and he maps out what are basically literal engineering requirements
And leak free. It turns out it's not just about having a competence is governed by its basal pressure, its overall physical length, and crucially, the thick length of the sphincter that is actually exposed to intra-abdominal pressure. If these physical dimensions and pressures are off by even a tiny fraction, the whole system breaks down.
Let's walk through exactly how this breakdown happens in real life. It happens in early stages of GORD. It starts simply as an increased number of those Basically, the gate just opens a bit too often. As the disease progresses, its basal tone, its resting grip gets weaker and weaker. And finally, in severe, becomes much shorter than normal, meaning it completely loses that supportive, clamping pressure from the abdomen.
That brings us to section 3, root causes of GERD, why the gate fails. The really crucial point to grasp here is that GERD pony, the culprits behind it are incredibly diverse. Structurally, something like a sliding hiatus hernia can compromise the valve. Or it could be systemic. Collagen disease can cause a massive loss of sphincter tone. Destructive operations like resections, cardioplasties, or a badly performed myotomy can actually bypass or completely destroy the incompetence mechanism. Actually, hold on a second. I want to pause on hernia confusion. We need to contrast a sliding hiatus hernia or paraesophageal hernia. While patients with severe GORD often do have a sliding hernia, the vast majority of people walking around with this type of hernia actually don't have significant reflux at all. Crazy, potentially very dangerous structural condition. It is absolutely vital not to mix these two up when looking at structural risks. All right, heading into our final section, section 4, modern trends and complications, lifestyle impacts. I want to throw this question out to you to kick off this section. Why is GORD, by far, the
the most common upper gastrointestinal condition in westernized countries today. Think about it. It sets up this truly fascinating paradox between the triumphs of the pitfalls of our modern lifestyle. Just look at how the dynamics of the last 30 years. It's wild. On the decreasing side, better socioeconomic conditions have drastically reduced Helicobacter pylori infections. And because of that, we've seen a massive, fantastic drop in. That is a huge win for medicine. But on the flip side, the lack of that H. pylori bacteria might actually lead to increased acid secretion. The net result of all this, an absolute explosion in GERD incidence and tragically, a parallel rise in lower esophageal cancer. The harsh reality, when that mechanical gate fails, the chemical consequences are brutal, and the damaging agents and pancreatic secretions creeping into your esophagus. Your delicate esophageal mucosa simply is not built to handle those kinds of caustic fluids. The severity of the resulting inflammation, a complication we call reflux esophagitis, depends entirely on two things: the concentration of the and exactly how long they stay in contact with your tissue.
This transparent 3D cutaway shows a healthy human thorax, zooming in to focus on a properly closed gastroesophageal junction. Under normal physiological conditions, this barrier remains tight. Or GERD, occur esophageal sphincter, or LES, undergoes a transient relaxation, rendering it incompetent. With the physical barrier compromised, and pepsin flow freely in a retrograde direction, washing directly upward into the distal esophagus. The esophageal lining is not equipped for this chemical exposure. The initial morphological response is a superficial reddening and erythema of the squamous mucosa, a finding classified clinically. Secondary neuromuscular spasms, severe histological changes, and microaspiration alongside basic chemical irritation. Because this disease involves both physical tissue destruction and invisible mechanical dysfunction, diagnosing it accurately requires a multimodal approach. Clinicians must, as it ascends from the incompetent LES, reveals how specific symptoms develop. Patients typically report retrosternal pain, which actually stems from two distinct origins. The first, mucosal chemical irritation, which the patient perceives as a burning sensation. The second origin is secondary esophageal muscle fermentation. It is posture dependent, worsening when lying down, stooping, or wearing tight abdominal garments. Because this spastic pain often radiates down the arms, it closely mimics the presentation of angina pectoris. These same spastic motors derive the dysphagia progresses from a functional issue to a morphological one. Repeated direct tissue injury is localized edema. This leads to chronic inflammation, and as the tissue attempts to heal, it lays down thick fibrotic scarring. In advanced cases, this heavy fibrosis culminates in a frank stricture. The esophageal wall stiffens, causing the severity of bleeding from these ulcers is entirely dictated by the underlying histology of the tissue. Looking at this side-by-side histological cross-section, the left panel demonstrates how ulcers form on the native epithelium of the esophagus. They typically remain shallow and superficial. The chronic acid exposure has caused the native cells to undergo gastric-type columnar epithelium. Because of this cellular shift, ulcerations here can penetrate significantly deeper. Ulcer breaches the underlying vascular bed so deeply, it presents with specific clinical signs. Patients frequently develop chronic anemia and test positive esophageal symptoms, the dual result of direct chemical tissue destruction and the body's own secondary neuromuscular and fibrotic defense mechanisms reacting to that injury. Continuing superiorly, the refluxate eventually reaches the top of the esophagus, encountering the esophageal sphincter. Acid exposure at this upper boundary triggers this specific cricopharyngeal spasm is responsible for a classic patient complaint, the persistent sensation of a foreign body lodged in the throat, known as the globus, frequently accompanied by an inability to initiate swallowing. Pharynx. This anatomical map highlights the three distinct paths this microaspiration can take: oral, laryngeal, and pulmonary. Following the pulmonary path, chronic aspiration into the lungs introduces acid directly into the lower respiratory tract. This causes asthma exacerbations, chronic cough, and in severe cases, recurrent pneumonia and lung abscesses. The laryngeal and oral paths result in upper airway damage. The vocal cords become inflamed, leading to chronic hoarseness and laryngitis, while acid reaching the oral cavity causes direct dental erosion.
There is a critical diagnostic caveat here. While respiratory symptoms frequently accompany GERD, if they are definitively caused, consist of the entire respiratory and upper aerodigestive tracts, making the clinical picture highly complex. To map the extent of this disease, clinicians begin with standard structural diagnostic tools, typically starting with radiography via a primary clinical utility of a barium swallow is to map gross anatomical abnormalities. It efficiently identifies hiatal hernias. Visualization demonstrates the modality has a critical limitation. Because it only captures a brief snapshot in time, radiologists fail to observe spontaneous free gastroesophageal reflux in approximately 50% of patients who are ultimately confirmed to have the disorder. To achieve direct morphological assessment and overcome this high false negative rate, the clinical gold standard is flexible video endoscopy. This clinical matrix out standardized endoscopic grading scale, which categorizes the physical damage from grade 0 to grade 4. The pathology progresses from grade 1 erythema to grade 2 ulcerin to grade 3 wall stiffening, up to grade 4 frank stricture. Endoscopy also allows for direct tissue sampling. To accurately diagnose Barrett's esophagus and its metaplastic changes, the required protocol dictates that biopsies must be taken more than 3 centimeters above the gastroesophageal junction. Modern flexible endoscopy, which procedure without general anesthesia, has rendered traditional esophagoscopy largely obsolete for routine lower gastrointestinal evaluation. Rigid instruments do retain one specific clinical indication. They provide superior visualization of the complex lower view. For examining the deep layer wall beneath the mucosa, clinicians utilize endoscopic ultrasonography, or in cases of severe disease progression, EUS is highly effective for adenocarcinoma and facilitating fine needle aspiration of adjacent, potentially compromised lymph nodes. A limitation remains. Endoscopic tools map the physical damage left behind by acid, but they cannot measure the transient dynamic barriers that initiate the disease. This leaves the 50% of patients who exhibit severe symptoms but no active structural reflux during standard imaging. Evaluating them requires physiological function tests. The first of these tests is high-resolution esophageal manometry, deployed via a transnasal catheter. This warm and cold color gradient, it identifies deficits in the lower esophageal sphincter in real time, showing precise and where the mechanical barrier fails. The ultimate physiological monitor is the 2-hour ambulatory multi-channel intraluminal impedance pH test. While traditional pH monitoring only tracks acidity, impedance testing detects the physical presence of refluxate. This gives it the unique capability to register non-acid liquid and gaseous reflux events that pH testing completely misses. Functional testing translates invisible neuromuscular deficits into measurable, actionable clinical data, providing a detailed map of the patient's esophageal physiology. This cinematic pullback through the thorax reverses the pathophysiology timeline, tracing the pathology from permanent strictures back through inflammation to the initial sphincter relaxation. Reflux esophagitis is driven by a core duality. It is the combination of direct chemical tissue injury and the complex secondary neuromuscular spasms that arise in response. For clinicians, the core diagnostic rule is to bridge the gap between a patient's subjective symptoms and objective, measurable disease markers. Achieving this, a multimodal diagnostic pathway. The structural assessment of flexible endoscopy must be seamlessly integrated with the functional mapping of high-resolution manometry and by precisely matching the diagnostic tool to the mitigate the risk of adenocarcinoma and deliver targeted, effective intervention. Of the upper GI tract. You are seeing a perfectly closed, insulated system designed with one specific job, taking food and liquid and efficiently pulsing it downward in complete containment. But context is everything. This cross-section highlights a central compartment called the mediastinum. Notice how the esophagus acts as a central pillar here, packed tightly against highly sensitive, completely sterile organs like the trachea, the aorta,
the heart, and the lungs. Because this biological tube shares actual physical walls with these vital systems, it doesn't have a buffer zone. Any structural failure in the esophagus instantly threatens the surrounding chest cavity. The esophagus operates as a high-traffic highway, routing through the body's most vulnerable real estate. Look at what happens when that structure fails. A sudden, forceful rupture tears directly through the muscular wall of the tube. Clinically, this physical breach is known as an esophageal perforation. If the tear goes untreated, the mortality rate is high. From the moment that wall gives way, medical teams have a strict 24-hour window to intervene before the condition likely becomes fatal. A localized structural defect becomes an immediate race against systemic biological collapse. The boundary of the esophagus can be breached from two directions, outside in or blown out from the inside out. Traumatic causes are often the most straightforward. Swallowed foreign bodies, like a sharp fishbone, can physically scrape and puncture the tissue as they travel down. This map shows where objects typically get stuck: top, at the level of the aortic arch, and in the distal esophagus, just above the cardia. Medical instruments can also be the cause. Tools like dilators or endoscopes can match and perforate the esophageal wall. Then there is generates so much internal pressure that the esophageal wall spontaneously ruptures outward. In rarer cases, the tissue is weakened by pathology. Ingesting corrosive chemical agents like lye can eat through the lining, or a carcinoma can penetrate the full thickness of the wall. Whether the weapon is a swallow, a medical scope, or severe internal pressure, the body's protective isolation is lost. The immediate aftermath is a toxic spill. In this spatial map, you can see how escaping air, bacteria, the location of the dictates where the damage spreads. If the perforation happens in the mid-esophagus, it floods the right pleura. If it happens lower down in the distal esophagus, it dumps into the left pleura. This influx of fluid and air restricts the lungs, leading to a pneumothorax and it into shock. And it's like squeezed by each heartbeat. Since the internal spill is invisible from the surface, clinicians must identify other cardiac and abdominal emergencies. Doctors must act immediately. They deploy a specific sequence of imaging to confirm the esophagus is ruptured. The first line of defense is an erect chest X-ray. Doctors are checking for a widened central chest cavity or dark pockets of trapped air that can even displace the trachea forward. As seen here, the patient swallows water-soluble gastrographin, which glows as it leaks through any tear. It replaces standard barium because it identifies the breach without causing chest cavity inflammation. In certain cases, separate from our internal organs. When that protective barrier ruptures, a catastrophic medical emergency begins. The immediate result is a breach. Highly corrosive gastric fluid, specifically anterior, posterior, and lateral chest X-rays, taken with the patient in an erect posture. This anterior-posterior X-ray reveals the diagnostic signs of a thoracic perforation. You can observe prominent mediastinal widening here, along with air distinctly outlined against the left pleural surface, indicating gas has escaped the digestive tract. If the rupture occurs higher up in the cervical esophagus, the primary evidence shifts to the lateral view. This radiograph shows abnormal air trapped in tissue spaces. These plain X-rays confirm a leak exists, but a contrast study is required to locate it. This gastrographin series tracks the swallowed medium. Focusing on panels A and B, this cloud-like extravasation is visual proof of the medium actively spilling into the surrounding cavity. In cases where gastrographin swallows fail to detect the specific site of the leak, the examination is repeated using barium as a necessary fallback. Mapping the exact location and extent of this extravasation determines the specific surgical approach required for repair. While the radial cavity, simultaneously, the severe inflammatory response leads to hemoconcentration caused by the high volume shift of response depends entirely on the location of the injury, starting with perforations drainage to clear the infected fluid, followed by direct primary closure of the tissue perforation itself. If the tissue is already too degraded to hold a suture, primary closure becomes impossible. The backup procedure is to insert a cervical esophagostomy tube directly through the perforation. Surgeons route this tube out through a small stab wound in the neck. This establishes a controlled fistula, allowing the dangerous fluids to drain safely outside the body. A neck perforation is critical, but its anatomical accessibility allows drainage quickly, preventing the infection from sinking down the thoracic cavity. Survival relies on operating the angle of attack, catching the perforation early enough for surgeons to preserve the patient's native esophagus while stopping the spread of. But when diagnosis is delayed in a mid-thoracic perforation, opportunity for simple repair passes. The healthy tissue rapidly becomes purulent. Simple organ repair is no longer an option. The highly infected tissue simply they will tear through the muscle. Controlling the mediastinal infection requires a complete esophagectomy, the physical removal of the esophagus itself. Surgeons must surgically close off the cardia at the top of the stomach to seal the lower digestive tract, while routing the remaining colon. A delay in diagnosis forces the surgical repair, committing the patient to a significant and permanent physiological alteration to ensure survival. Surviving the initial surgery does not eliminate the risk. The clinical focus must immediately shift to the high probability of postoperative complications. The medical team must monitor for secondary infections, requiring prompt surgical drainage for complications like mediastinitis, empyema, and deep internal abscesses forming in the lungs or below the diaphragm. This cross-section highlights a specific threat. Because the descending aorta sits right next to the esophagus, the pooling septic fluid can of the major blood vessel, creating a risk of internal hemorrhage. Because from the aorta, so the tubing doesn't physically rub through the weakened tissue. Aftermath of the perforation turns the patient's own chest cavity into a highly environment, demanding constant vigilance against secondary events. The outcome of an esophageal perforation depends heavily on the timing of intervention. On the left, catching the breach immediately allows for an intact digestive, ravaged chest cavity, the total loss of the esophagus, and a difficult battle against systemic failure. Managing an esophageal perforation requires meticulous operative technique, but in the end, time is the ultimate life and death.
Esophageal perforation can occur from mechanical injury. Excessive force or tight strictures increase. Other symptoms include sudden back pain, neck pain, and difficulty swallowing. Subcutaneous emphysema may also present. Contact your doctor if these occur after a procedure.
Esophageal perforation leads to mediastinitis. As inflammation worsens, patients present with severe chest pain, high fever, and rapid tachycardia, rapidly progressing to life-threatening sepsis.
Mediastinitis can progress rapidly, spreading into the pleural cavity. Empyema.
Antibiotics are critical. Surgical repair seals any esophageal tears. Covered stents provide an endoscopic option. Prompt care saves.
Infection spreads into the mediastinum. It tracks further into the pleural cavity. A pleural drainage installation begins the washout, is continued until the fluid runs completely clear.
And it's monitoring, providing vital IV fluids and nutrition. For mediastinitis, remember this: early diagnosis, prompt surgery, drainage.
A 2 millimeter tear in the intestines will cause severe illness. A 2 millimeter tear in the esophagus will rapidly cause death. The extreme mortality rate is by a single architectural flaw. Looking at this 3D cross-section of the esophageal wall, the deficit becomes clear. By stripping away the muscular layers, we reveal a critical omission. The esophagus lacks the outermost serosal barrier. As we follow the track down to the stomach, a thick, tough serosal layer suddenly appears. Air means the esophagus operates with a significantly lower baseline tensile to resist outward physical stress. This fragile mediastinum, a completely stable cavity in the center of the chest, aorta, and the major pulmonary vessels. The esophagus acts as a high conduit for food, liquids, and bacteria, routing them straight through this critical sterile zone without the standard biological shielding. The absence of the serosa leaves the esophagus uniquely predisposed to catastrophic structural failure when the pressure dynamics inside the chest abruptly change. That tensile strength is tested to its absolute limit during sudden physical stress, specifically emesis or vomiting. This vector graphic maps the baseline physics of the chest cavity. The lungs remain inflated because they are surrounded by a constant negative pressure, which constantly pulls outward against the esophageal wall. During emesis, a violent the distal esophageal lumen must rapidly when the stress exceeds, the result is spontaneous rupture, clinically known as Boerhaave syndrome. The muscle layers separate. The wall abruptly, violently ejecting the contents of the stomach. A highly corrosive slurry of gastric acid, digestive enzymes, and oral flora flood into the sterile mediastinum. Boerhaave syndrome is not an infectious disease process. It is a sheer biomechanical failure driven by extreme pressure gradients acting on an unshielded pipe. Spontaneous rupture is dramatic, but the highest rates of perforation today are iatrogenic, resulting from medical instrumentation. The very tools used to diagnose gastrointestinal disease pose an inherent hazard to the fragile esophageal wall. The invention of flexible fiber optic endoscopes has reduced the firmly to specific topographical esophagus, pharyngeal sphincter at the top. The aortic arch narrowing at the top is exceptionally vulnerable during intubation or endoscopy. As the patient's neck is hyperextended, the cervical spine acts as an anvil. If an older patient has osteophytes, bony outgrowths on the vertebrae, the rigid endoscope can crush the esophageal mucosa directly against them. Iatrogenic perforations occur exactly where rigid medical instruments clash with rigid human anatomy. When the breach occurs, the patient immediately experiences agonizing sudden pain. Because of the location, this is frequently misdiagnosed as a myocardial infarction or perforated peptic ulcer. The physical deterioration is rapid. The patient collapses into septic, defined by tachycardia, severe hypotension, and tachypnea as the contamination sets in. As the esophagus leaks, this coronal diagram tracks the migrating air, pneumomediastinum. Gas travels up, trapping itself under the skin to create crepitus, a crackling texture when touched. Alternatively, air wedges in the lower median between the heart and chest wall. This produces Hammond's sign. Even if the patient holds their breath, a distinct crunching sound is audible through a stethoscope, synchronized perfectly with each heartbeat. If the perforation is in the mid-esophagus, it typically ruptures into the right pleura. A lower tear compromises the left pleura. Both result in severe dyspnea and collapse. Gas acts as an internal alarm system. Acoustic signals, a physician can map the exact trajectory of the internal breach. Clinical signs raise the suspicion of a rupture, but radiographic proof is required immediately before a surgeon will open the chest. The standard erect chest radiograph is the fastest initial tool for detecting structural thoracic anomalies. The X-ray reveals specific markers, a distinct widening of the mediastinal and abnormal air pockets outlining the left pleural surface. To pinpoint the exact coordinate size of the defect, a contrast radiography swallow study is required. There is a strict pharmacological rule for this initial. Physicians must use only water-soluble contrast mediums, like gastrograph. Standard barium contrast is explicitly forbidden. If barium leaks through an esophageal tear, it triggers a catastrophic, highly destructive inflammatory response in intestinal tissues. Precise radiographic mapping is the only way to transition a patient safely from diagnostic uncertainty into targeted surgical intervention. Surgical management of an esophageal perforation revolves around one unforgiving variable, the 24-hour tissue integrity threshold. If the tear is diagnosed in under 24 hours, the esophageal tissue remains structurally sound. It holds sutures, allowing for direct primary repair. Model, the thorax is asymmetrical and anatomy forces different surgical access routes depending on the tear's height. For upper esophagus above the next step, they reinforce the closure by wrapping it with a flap of adjacent healthy pleura or a gastric fundus. Early surgical intervention relies heavily on topographical engineering, using healthy surrounding tissues to buttress a fundamental structural defect. If the diagnosis is delayed past the 24-hour mark, the physiological of the mediastinum shifts entirely. The area is overwhelmed by inflammation, massive infection, and necrosis. Late surgery encounters immediate biomechanical failure. The necrotic, friable paper, making it is impossible, surgeons shift to salvage these. This begins with aggressive pleural drainage and may involve a covered stent over the defect. The most radical damage control procedure is an esophagectomy combined with a cervical esophagostomy. The gastrointestinal tract is entirely diverted out through a stoma in the neck to stop continuous mediastinal contamination. This diversion dictates long-term reconstructive aftermath. Patients require, like a substernal colon interposition, face mediastinal abscesses, severe aspiration pneumonia, and catastrophic hemorrhage if the aorta is eroded by sepsis or a poorly placed tube. The ultimate predictor of mortality in esophageal perforation is not the size of the initial structural breach. Rather, it is the exact duration the sterile mediastinum is exposed to the catastrophic chemistry of the gut.
If you found this video informative, please like and share, comment what you would like to see next, and subscribe to the channel to get notified about future informative videos.
When a healthy newborn arrives, two vital actions happen automatically within seconds. First breath of air, and the infant instinctively swallows to clear saliva and prepare for feeding. But in a small percentage of deliveries, this seamless routine breaks down immediately. When the newborn attempts continuously from the mouth, the infant begins a dangerous blue tint called cyanosis spreads across their skin due to a sudden lack of oxygen. This immediate medical emergency is the hallmark of a condition known as esophageal atresia. To understand the crisis, we have to look at the internal anatomy. Normally, the esophagus is a continuous muscular tube routing food from the throat directly down to the stomach. But in a baby born with this condition, that tube fails to develop properly. Instead of reaching the stomach, it terminates abruptly into a dead end, forming a blind pouch. And that roadblock is usually accompanied by a secondary, highly dangerous complication. While the upper section of the esophagus pouch, the lower, disconnected section of the esophagus incorrectly pipe, creating an abnormal channel called a fistula. This anal crosswiring creates an immediate, severe physiological threat. With every breath the baby takes, useless air is pumped directly into the stomach through that false connection. And worse, any swallowed fluid, whether milk or just saliva, spills over and risks being aspirated directly into the lungs. A microscopic routing during embryonic development turns the two most natural, life-sustaining actions, and swallowing, into an immediate dual threat to the newborn's survival. Doctors have this physical disconnect rapidly. They start with an elegant physical diagnostic test. A soft rubber catheter is carefully passed through the infant's mouth. If the tube hits a firm obstruction at roughly 10 centimeters down, it forms the roadblock. 5 variations of this anatomical defect, depending on where the pouches and fistulas form. However, one specific miswire dominates. In nearly 90% of cases, the upper throat ends in the blind pouch, and the lower tube attaches directly to the trachea. Accurately identifying this exact internal blueprint is mandatory. It's the only way a surgical team can safely design a specialized pathway to bridge the anatomical gap. Before making a single incision, the infant must be stabilized. The baby is placed in a precise 30-degree head-up position to keep stomach acids from traveling up the false tube into the lungs. Continuous suction is applied to the upper pouch to keep saliva out of the airway, and broad-spectrum antibiotics are started immediately. Once stabilized, the surgical intervention begins. The surgeon makes an approach through the right side of the chest wall. Using the diagnostic catheter, the surgeon disconnects the lower esophagus, a single continuous pipeline. This sequence of delicate disconnects the infant's internal plumbing, permanently eliminating the anatomical roadblock. Following the baby's chest is closed up, and an underwater sealed chest drain is left in place to safely manage fluids while the newly stitched connection begins severe mediastinal infection in the chest secondary operation to repair. Even after leaving the hospital, patients require long-term vigilance. Because the esophagus was surgically altered, issues like gastroesophageal reflux, or GERD, are common late complications, and roughly 20% of these infants will also need monitoring for associated congenital heart defects. Yet, the human body adapts remarkably well when properly realigned. With modern surgical techniques, the vast majority of these patients go on to develop nearly normal swallowing and esophageal function. A missing link in the body's internal blueprint initially presents as a terrifying structural crisis.
But through rapid diagnostic intervention, surgical engineering, that broken pipeline is permanently restored.
To the channel to get notified about.
This shows a gross type C anomaly. Instead of a continuous tube, the upper esophagus ends blindly. The lower esophagus forms a fistula off the trachea. Tracheal air continuously inflates the stomach, stabilizing the continuous suction of the upper pouch to clear the pooling secretions, and strictly avoiding which would only worsen the gastric distension. The team must rule out associated vectoral anomalies, such as severe vertebral defects, complex anorectal and cardiac anomalies, as well as renal malformations that frequently co-occur and can alter the surgical timeline. The operative mandate is exact: complete mechanical shared aerodigestive tract, closing the airway, and reconnecting the esophagus without compromising the delicate regional anatomy. Neonatal survival relies entirely on halting this aerodynamic cross-contamination. The surgeon must permanently isolate the airway and architect two completely to expose the operative field. The infant is placed in the left labitus position, providing direct access to the right hemithorax. This first cross-section shows exactly why a right-sided approach is mandated. Allows the surgical team to completely bypass the descending aorta, which dominates the anatomy on the left side. The surgeon executes a posterolateral thoracotomy, making the incision precisely through the fourth intercostal space. This illustration demonstrates the required muscle-sparing technique. The latissimus dorsi and cerebellum retracted rather than divided, maintaining their structural integrity while exposing the intact intercostal space below. Breaching the posterior medius. Surgeons utilize inside the pleural sac or approach directly through it, depending on the infant's specific anatomy. Once inside, the right lung is gently retracted anteriorly. This must be force to maintain respiratory and hemodynamic stability throughout the procedure. This atraumatic exposure provides a clear line of sight. It is the prerequisite for navigating the microscopic margins of error in the neonatal mediastinum. Posterior mediastinum, the immediate anatomical landmark is the azygos vein arch. This arch crosses directly over the operative site. It is require absolute precision to avoid vocal cord paralysis and foregut dysmotility. With the nerves secured, the surgeon traces the fistulous tract to its exact origin point on the membranous posterior wall of the trachea. Fine right-angle clamps are placed flush trachea, and the tract is surgically divided at its base, ensuring no residual tracheal diverticulum remains. This illustration shows the immediate repair. Tracheal defect is closed using interrupted absorbable monofilament sutures, creating a precise mucosa-to-mucosal seal. The surgeon floods the field with saline, and the anesthesiologist applies positive dilation, watching for any escaping air bubbles. Achieving an airtight tracheal seal permanently ends the respiratory contamination loop. The airway is secure. With the airway repaired, Phase 4 addresses the central mechanical dilemma, filling the gap between disconnected esophageal ends to restore gastrointestinal continuity. This introduces the tension-perfusion paradox. The surgeon needs mechanical length to bring the ends together, but mobilizing, destroying its blood supply. This dictates a highly asymmetrical approach to the patient. This vector diagram maps the strategy. Traction sutures pull the thick-walled proximal pouch superiorly to gain mechanical length. Conversely, the distal segment remains untouched. A microvascular overlay reveals its fragile blood supply. Dissecting severs these vessels, causing ischemia, anastomotic leaks. To prepare for the connection, the distal tip of the mobilized upper pouch is opened, matching its diameter cosa of both segments precisely. This is secured with 5-0 absorbable sutures. This specific technique prevents formation and allows the tissue to expand as the infant grows. Watch as a transanastomotic replogal feeding tube is carefully advanced past the repair and directed straight into the stomach. Once the tube is positioned, the anterior wall of the anastomosis is closed over it, completing the continuous digestive tract. Mastering this asymmetrical mobilization is the only viable method for achieving mechanical continuity without triggering ischemic failure. Phase 5 architecture. The respiratory and digestive tracts are now successfully separated. This split screen compares the anatomy. On the left, we see the original pathology where air and fluids crossed into the wrong system. On the right, we have the new physiological flow, where respiration and digestion are strictly isolated into independent pathways. Before beginning the closure, the operative field is thoroughly irrigated to clear any remaining debris. The ostomy tube is introduced and carefully positioned. This drain provides a necessary egress route, capturing any potential anastomotic leaks or pleural effusion that might accumulate postoperatively. Look closely at this illustration of the placement. A critical spatial rule dictates that the drain must remain adjacent to, but never rest directly against, the fresh anastomosis. Physical contact could cause mechanical erosion of the suture line. Drain placement acts as a passive defense system, protecting the fragile new anatomy from both fluid accumulation and direct mechanical trauma. This view shows the careful re-expansion of the right lung, restoring normal pulmonary volume within the thoracic cavity. The surgical team then performs a layered anatomical closure of the posterolateral thoracotomy incision. The ribs are re-approximated. This alignment is required to ensure optimal postoperative mechanics in the developing neonate. The retracted muscles are restored to their anatomical positions, and the procedure concludes with a standard subcutaneous skin closure using absorbable sutures. This protocol restores functional anatomy through precise spatial awareness, vascular preservation of the...
Like and share, comment what you would like to see next, and subscribe to the channel to get notified about future informative videos.
Right above the gastroesophageal junction lies a narrow span of tissue. Clinically, this distal segment zones in the human body. The primary weakness is self. The left posterolar structures, then the upper exact segment is forced to narrow abruptly as it tasses down through an opening in the diaphragm. Every time a person swallows, coughs, lifts a heavy object, or bears down, physical pressure focuses directly on this junction. The combination and a rigid anatomical bottle immense physical stress from both inside and out, creating the precise conditions for catastrophic failure. A sudden violent spike in intraesophageal, usually triggered by heavy retching or forceful vomiting, can easily push that weak left posterolateral wall past its mechanical limit. When the tissue fails completely, the result is Boerhaave syndrome, a spontaneous, full-thickness transmural rupture of the esophagus. Physicians rely on a diagnostic framework known as Mackler's triad to identify this specific blowout amid highly variable presentations. The presentation begins with the first two symptoms, severe, sudden lower chest pain that often radiates straight to the back, followed closely by a history of forceful vomiting. The third defining through the ruptured tract and tracks upward, a physician can feel a sensation when pressing on the skin of the patient's neck or chest. This chest X-ray shows exactly what clinicians look for to confirm the diagnosis. A clear pocket of mediastinal air, indicated by the arrows, that has leaked completely outside the esophagus. Any gastric fluid or air rapidly infects the chest cavity to fatal mediastinitis and sepsis. On an immediate surgical thoracotomy to open and stitch the tear. Distinguishing between severe gastrointestinal distress and a full-thickness structural collapse is an immediate matter of life or death. That same narrow choke point through the diaphragm also makes the distal esophagus high. An object, like a button battery, gets lodged in the induced tissue necrosis and perforation. This tissue also faces chronic chemical assault from below. Esophageal reflux dysphagia rewrites pale tissue in image A is entirely replaced by the silent acid erosion. Local mechanical and chemical actively rewrite the cellular integrity of the lower esophagus. If that cellular change progresses to esophageal cancer, a tumor length reaching 3 centimeters also facilitates a dangerous phenomenon known as skip metastasis. Malignant cells enter an uninterrupted line, utilizing it as an anatomical highway. Because this network lacks segmental barriers, a localized tumor at the gastroesophageal junction can send cancer cells straight up into the cervical nodes of the neck, making accurate surgical staging highly difficult. On the acute side, clinicians must also weigh superficial threats. A patient presenting with bright red bloody vomiting is often suffering from Mallory-Weiss syndrome. These comparative anatomical drawings highlight the specific mechanical difference. while Boerhaave syndrome on the right is a transmural rupture spilling to the internal mucosal and submucosal layers. Evaluating a patient at depth of tissue failure, from a superficial bleed to submucosal cancer to a full thickness blowout. The internal health of this entire 3 centimeter zone is heavily dependent on the elastic phrenoesophageal ligament. Together, they act as an extra mechanism is the primary barrier keeping stomach acid trapped in the abdomen. As tissues stretch or weaken, the anti-reflux barrier fails, allowing a hiatus hernia to form as abdominal contents push. In a sliding hiatus hernia, designated as type 1, the gastroesophageal junction itself shifts up into the thorax. This breaks the seal entirely, initiating the cyst that drives Barrett's esophagus. In contrast, during a paraesophageal hernia, the junction remains firmly below the diaphragm, but the upper portion of the stomach rolls upward, ballooning parallel to the esophagus. While the reflux barrier stays intact, the displaced stomach introduces immediate mechanical risks, including gastric volvulus, strangulation, and loss of blood supply, creating ascendancy. Treating a microscopic cellular mutation, repairing a massive structural herniation, all trace back to the same anatomical choke point. The outcome entirely on understanding the precise mechanical limits of the distal esophagus.
When a patient presents with an esophageal emergency, survival depends on measuring a single critical dimension: depth. Clinicians must immediately identify exactly how far a tear penetrates the structural wall of the tissue. Of trauma we look for is a Mallory-Weiss tear. This is a superficial longitudinal laceration that only breaches the innermost. These shallow tears are usually the mechanical result of severe retching. Because the damage is restricted to the surface, the management protocol is strictly conservative. The tissue typically heals spontaneously within 48 to 72 hours, suppression or a simple endoscopic clip to halt any persistent bleeding. Changes when the structural failure extends entirely through the tissue. This is Boerhaave syndrome, a complete rupture. In clinical terms, the tear is transmural. This structural collapse allows swallowed fluids and gastric acid to bypass the digestive and leak directly into the negative pressure space of the mediastinum. Containing that leak requires aggressive intervention. The protocol mandates strict nil per os, or NPO, status, immediate broad-spectrum repair. Even with rapid intervention, the contamination from a transmural rupture carries a mortality rate between 20 and 40. Physical trauma represents a highly acute, purely is equally vulnerable to chronic diseases, conditions driven by a failure of mechanics and internal pressure gradients. The esophagus functions as a highly regulated pressurized conduit. Moving ingested material from the pharynx to the stomach relies on a delicate harmony between the surrounding intrathoracic pressure and two surgical sphincters. Because this conduit sits within the thorax, its rest fluctuates between -5 and +5 millimeters of mercury during a standard respiratory cycle. When a swallow is initiated, the sphincter temporarily opens, allowing the bolus of food to enter the pressurized space. Once inside, a primary peristaltic wave takes over. This muscular contraction drives the intraluminal pressure up to approximately 25 millimeters of mercury, the bolus downward. The final checkpoint in the sequence is the lower esophageal sphincter, contains a continuous resting tone of about 20 millimeters of mercury. This pressure is driven by tonic myogenic activity, meaning the muscle itself generates independent of autonomic neural signals. This high-pressure zone relaxes the bolus pass before immediately down. The sphincter is reinforced by secondary anatomical structures, the oblique angle of entry, local mucosal folds, and the diaphragm, which all help seal off the stomach. Maintaining this precise 20 millimeter pressure gradient at the LES is the prerequisite for an intact esophagus. When the barrier between the stomach and esophagus becomes incompetent, it's esophageal reflux disease, or GERD. The primary functional failure is a drop in baseline resistance. The basal resting pressure of the LES falls below the necessary 20 millimeter threshold. Looking at this anatomical panel illustrates this structural failure. The blue arrows point to the relaxed, open sphincter, allowing green gastric fluids to wash upward into the esophageal body. To confirm this mechanical breach, clinicians perform an acid reflux test. It detects a decrease in pH to less than 4, a proof of severe, ongoing gastroesophageal reflux. Over time, mechanical failure exposes the esophageal mucosa to repeated destroying its structural integrity.
Clinicians use the Los Angeles classification of reflux esophagitis to grade the severity of that chemical damage. The system tracks the progressive expansion of mucosal breaks, scaling from minor A lesions under 5 millimeters all the way to grade D, where tissue damage involves more than 75% of the esophageal circumference. This destructive cascade can be triggered by pharmacological and lifestyle factors that lower, such as excessive alcohol consumption, smoking, fatal withdrawal, or the use of beta-adrenergic agents. What begins as a failure of physical structure, corroded by cardia. Achalasia is a rare chronic neurodegenerative disorder. It creates a rigid mechanical obstruction rather than a loose tent barrier. This diagram highlights the anatomical contrast. Focusing on the right panel, you can see the weakened smooth muscle and the distinct narrowing at the lower. This is a dual mechanical failure. The LES loses to relax, and simultaneously, the esophageal body loses its normal rhythmic peristalsis. Because the transit mechanism is broken, swallowed food cools above the blockage. This stretches and dilates the esophagus. This backlog produces immediate clinical symptoms, most notably spill over. They trigger secondary symptoms, including nocturnal coughing spells and unintended due to the mechanical difficulty of moving food into the stomach. From the incomplete relaxation of the sphincter, gastroenterologists rely on high-resolution manometry as the definitive gold standard diagnostic test. Chicago classification system, this manometry data allows medical professionals to categorize the disease into one of 3 distinct clinical types to predict treatment response. While GERD destroys the esophageal barrier through functional weakness, dysphagia destroys the conduit's ability to operate through neurodegenerative rigidity. As the underlying nerve damage driving achalasia is irreversible, management cannot rely on medication alone. To restore transit, physicians must mechanically weaken or physically break the tight LES muscle fibers so that food can pass via gravity. Physical intervention is pneumatic dilation. In this specialized high-pressure balloon is inflated inside the sphincter. The force physically stretches and tears the constricted muscle fibers apart. For a more targeted approach, physicians utilize an advanced endoscopic surgery called oral endoscopic myotomy, or POEM. During a POEM procedure, passed through the mouth, allowing the surgeon to precisely cut the inner muscle fibers of the LES from the inside out. The primary external surgical alternative is the Heller myotomy. This laparoscopic approach cuts the external muscle fibers, destroys the barrier. It is often paired with subsequently developing reflux. For patients whose surgical risk is endoscopic Botox injections can temporarily paralyze and relax the muscle, providing a short-term mechanical reprieve. From deploying clips to seal a mucosal tear, to manually tearing a...
Please like and share, comment what you would like to the channel to get notified about future informative videos.
The esophagus functions as a multi-compartmental transit corridor, continuously adapting its architecture to the shifting spatial constraints of the neck, the mediastinum, and the abdomen. This descent is divided into 3 anatomically distinct zones: the cervical, thoracic, and abdominal compartments. While the muscular wall forms a single physical continuum, the infrastructure supporting it is fragmented. Supply, venous drainage, and lymphatic networks terminate abruptly at regional boundaries, with virtually no overlap between the upper, middle, and lower thirds. This regionality dictates the behavior of clinical pathology. It confines portosystemic varices to the lower segment and ensures that esophageal carcinoma entirely different paths of lymphatic spread. Compartment. Here, the esophagus is tightly packed into no room for lateral expansion. In this axial cross-section, the anterior boundary is defined by the esophagus's tight apposition against the posterior membranous wall of the trachea. Along the lateral margins, the recurrent laryngeal nerves run within the tracheoesophageal grooves, flanked further out by the 2 rest directly against the prevertebral fascius colli muscles and the cervical vertebrae. In this upper third, muscular and lymphatic parameters are highly localized. Arterial flow is supplied by the inferior thyroid artery. We enter the superior mediastinum. The esophagus initially maintains its position between the trachea and the vertebral the aortic arch, descending along the at the seventh thoracic vertebra, it inclines leftward, cross aorta, to reach the diaphragm. Simultaneously, the organ undergoes a neurological restructuring driven by the embryonic rotation of the stomach. This vagus nerve to the anterior wall and the right vagus nerve to the posterior wall, forming the esophageal plexus seen here. From a posterior perspective, right-sided relations, the right pleura and the azygos vein as it arches forward to meet the superior mediastinal node. Aorta, combined with this dual vagus middle segment, one of the most anatomically restricted zones for surgical access. 10th thoracic vertebra, the esophagus passes through the diaphragm to enter the abdominal cavity. Its immediate posterior abdomen are the left crus of the diaphragm and the left inferior phrenic artery. To stabilize this opening, the transversalis fascia on the diaphragm's to form the phreno-esophageal membrane. This allows the esophagus to move during swallowing and respiration, contains a critical portocystis where two separate venous systems meet. Systemic drainage for the azons in the thorax converges here with the portal drainage of the left gastric vein. In portal hypertension, this collision zone becomes a bottleneck. High-pressure portal blood backs up into the fragile esophageal plexus, causing life-threatening varices. The descent ends at the esophageal junction by the Z-line, where squamous epithelium turns to columnar, is unreliable, as the distal esophagus frequently contains columnar cells. Similarly, defining it by the macroscopic point where the tube meets the of hiatal hernias. The most accurate theory relies on microscopic muscular and surface landmarks. The true anatomical junction is the point where the circular muscle layer of the esophagus interlocks with the oblique sling fibers of the stomach. These shifting topographical relations, rigid texture, create the specific zones of vulnerability that define esophageal medicine.
The human esophagus is a 25 transit conduit, bridging the pharynx above down to the stomach below. To complete this journey, the organ must traverse three anatomic. Below lies the extensive thoracic segment, the diaphragm, forming a short abdominal segment connecting to the stomach. Each step of this descent subjects the muscular tube to drastically different external compressions and distinct vascular territories required to predict and ultimately avoid fatal surgical and endoscopic complications. This lateral mapping establishes the exact point of the esophagus at the C6 vertebral level of the cricoid cartilage. This C6 origin marks the narrowest point in the entire gastrointestinal tract, measuring just 14 millimeters in diameter. Looking at this reference, this uppermost constriction sits exactly 15 teeth. Because of this tight diameter, it presents the primary risk site for iatrogenic perforation during endoscope insertion. This anatomical model of the posterior pharyngeal wall reveals a known as Killian's triangle. The superior boundary formed by oblique fibers of the thyropharyngeus muscle, and the inferior boundary by transverse fibers of the cricopharyngeus muscle. Under normal conditions, these muscles coordinate seamlessly. However, a pathology of neuromuscular incoordination, the pharyngeus muscle fails to relax in a timely manner during the swallowing reflex. This failure causes a massive spike in intraluminal pressure within the hypopharynx, driven directly backwards through the of Killian's triangle. The resulting outpouching, diverticulum, is a predictable biomechanical failure. It forms entirely because these specific muscular boundaries create an unavoidable. Moving downward from the neck, the esophagus enters the complex of the superior and posterior mediastinum. This posterior view maps critical spatial relationships. The trachea sits anteriorly, and the vertebral column posteriorly. Notice how the esophagus compartmental transit corridor continuously adapting its architecture to constraints of the neck, the mediastinum, and the abdomen. This descent is divided into three anatomically distinct zones: the cervical, thoracic, and abdominal compartments. While the muscular wall forms a pathology, it confines portosystemic varices to the lower segment and ensures that esophageal carcinomas follow three entirely different paths of lymphatic spread. To accurately predict these pathologies, we must examine the specific anatomical relationships and support systems unique to each of these three territories. The descent begins in almost no room for lateral expansion. In this axial cross-section, the anterior boundary is defined by the esophagus's tight apposition against the posterior membranous wall of the trachea. Along the lateral margins, the recurrent laryngeal nerves run within the tracheoesophageal grooves, the common carotid arteries. Posteriorly, the tube rests directly against the prevertebral fascia, the longus colli muscles, and the cervical vertebrae. In this upper third, the vascular and lymphatic parameters are highly localized, applied by the inferior thyroid artery, and lymph drains directly into the deep cervical nodes. Due to this spatial congestion, cervical esophageal carcinomas cannot expand significantly before they compromise the airway or cause vocal cord paralysis via recurrent laryngeal nerves. As we enter the superior mediastinum, the esophagus initially maintains its position between the trachea and the vertebral column. The esophagus navigates the great vessels by passing behind and right of the aortic arch, descending along the thoracic aorta's right edge. At the seventh thoracic vertebra, it inclines leftward, crossing it. This rotation pulls the left vagus to the posterior wall, forming the esophageal plexus seen here. From a posterior perspective, we can see the right-sided relations, the right pleura, and the azygos vein as it arches forward to meet the superior vena cava. The middle third draws supply from esophageal branches of the thoracic aorta and bronchial arteries, with lymph draining to superior mediastinal nodes. The complex crossing of the aorta, combined with this dual vagus wrapping, makes the middle segment one of the most anatomically restricted zones for surgical access. At the level of the 10th thoracic vertebra, the esophagus passes through the diaphragm to enter the abdominal cavity. Its immediations in the abdomen are the left crus of the diaphragm and the left inferior phrenic artery. To stabilize this opening, the transversalis fascia on the diaphragm's underside extends upward to form the phrenoesophageal membrane. This elastic membrane allows the esophagus to move during swallowing and respiration, providing the structural limit necessary to prevent the stomach from displacing upward. The lower third is supplied by the left gastric and inferior phrenic arteries, with lymph draining to the gastric and celiac nodes. This lower segment also contains a critical portosystemic anastomosis, where two separate venous systems meet. Systemic drainage for this collision zone becomes a bottleneck plexus, causing life-threatening varices. The descent ends at the esophagus. Finding the exact location of this terminus is an area of ongoing anatomical debate. Defining the junction by the Z-line, where squamous epithelium turns to columnar, is unreliable, as the distal esophagus frequently contains columnar cells. Similarly, defining it by the macroscopic point where the tube meets the gastric pouch is often obscured by the presence of hiatal hernias. The most accurate relies on microscopic muscular architecture rather than surface landmarks, the true anatomies of the stomach. These shifting topographical relations, rigid segmental vessels, and precise muscular architecture create the specific zones of vulnerability that define esophageal medicine.
The human esophagus is a 25-centimeter transit conduit, bridging the pharynx above down to the stomach below. To complete this journey, the organ must traverse three anatomically distinct pressure cavities: the cervical, the thoracic, and the abdominal regions. This diagram divides the organ into three regional zones. The brief cervical segment terminates at the first thoracic vertebra. Below lies the extensive thoracic segment. Finally, its vascular territories. Navigating these regional transitions is required to predict and ultimately avoid fatal surgical and endoscopic complications. This lateral mapping establishes the exact origin point of the esophagus at the C6 vertebral level, correlating precisely with the lower border of the cricoid cartilage. This C6 origin marks the narrowest point in the entire gastrointestinal tract, measuring just 14 millimeters in diameter. Looking at this reference, this uppermost constriction sits exactly 15 centimeters, or roughly 6 inches, from the incised teeth. Because of this tight diameter, it presents the primary risk site for iatrogenic perforation during endoscope insertion. This anatomical model of the posterior pharyngeal wall reveals a natural structural dehiscence known as Killian's triangle. The superior boundary is formed by oblique fibers of the thyropharyngeus muscle, and the inferior boundary by transverse fibers of the cricopharyngeus muscle. Under normal conditions, these muscles coordinate seamlessly. However, a path lacks in a timely manner during the swallowing reflex. This failure causes abdominal pressure within the hypopharynx. Driven by a pulsion mechanism, this chronic pressure forces the mucosal and submucosal layers to herniate directly backwards through the muscle-deficient zone of Killian's triangle. The resulting outpouching is a predictable biomechanical failure. It forms entirely because these specific muscular boundaries create an unavoidable anatomical weakness. Moving downward from the neck, the esophagus enters the complex, crowded space of the superior and posterior mediastinum. This posterior view maps critical spatial relationships, the trachea anteriorly and the vertebral column posteriorly. Notice how the descending thoracic aorta runs tightly along the esophagus's left side before the tube crosses directly in front of it at T7. Throughout this descent, the organ weaves laterally. It inclines slightly to the left at the root of the neck, returns to the midline by T5, and shifts left once again as it approaches the diaphragm. This diagram outlines two major mid-thorax constrictions caused by external compression. The second constriction occurs at T4, where the tube is crossed by the aortic arch. The third sits lower, caused by rigid compression from the left main bronchus. Vascular and respiratory crossings create fixed mechanical bottlenecks. They determine exactly where ingested foreign bodies will reliably impact, and endoscopists must exercise extreme caution. Below the surface of these external mechanical constraints lies an internal tissue architecture that presents a completely different set of risks. Unlike the strictly segmental lymphatic drainage found throughout the rest of the gastrointestinal tract, the esophageal lining is architecturally unique. This cross-section reveals a continuous, longitudinal submucosal lymphatic plexus running vertically without segmental barriers. Acting highway, it allows malignant cells to travel long distances within the wall before exiting into external lymph nodes. This architecture drives a phenomenon known as skip metastasis, where cancer cells bypass the nearest regional lymph nodes and settle in distant nodal basins. Because of this unbroken vertical flow, a localized tumor situated in the lower esophagus can drain directly upward into the cervical nodes of the neck, completely skipping the mediastinal nodes situated closely by. This staging highly unpredictable, requiring surgeons to perform extensive, multi-field lymph node dissections to ensure complete oncological clearance. Moving to the base of the thorax, the esophagus reaches the T10 vertebral level, where it must pierce the muscular floor of the chest cavity to enter the abdomen. This superior view of the diaphragm displays the esophageal hiatus, an elliptical opening formed by the splitting of the medial muscular fibers of the right crus. The esophagus is anchored within this hiatus by the phrenoesophageal ligament, reinforcing the lower esophageal sphincter to block acid reflux. When these tissues weaken, a type 1 sliding hiatus hernia occurs. The gastroesophageal junction shifts upward into the thorax, disrupting the anti-reflux barrier and causing severe gas disease by contractions like gastric volvulus, strangulation, and ischemia. Beyond structural risk, the critical vascular landscape, the portosystemic anastomosis. Here, the portal system's left gastric vein converges directly with the systemic venous system's azygos vein. In the presence of portal hypertension, often caused by liver cirrhosis, blood flow is obstructed through the liver, causing massive back pressure to build up within this valveless network. This immense pressure forces blood to flow backward, flooding into the fragile submucosal veins of the lower esophagus, which dilate and swell varices. Sitting just beneath a thin mucosal lining, these vessels are structurally unequipped to handle high-pressure flow, and are designed for the load. Finally, this nerve map highlights the autonomic control system overlying the tract, supplied by the vagus nerves and thoracic sympathetic trunk. Sympathetic descent. The left vagus nerve forms the anterior vagal trunk, while the right forms the posterior vagal trunk. This distinct anterior left and posterior right orientation is a direct result of the angular weaknesses of the cervical spine to the uninterrupted lymphatic highway of the thorax and the venous vulnerability of the abdomen. Safe clinical practice relies on understanding that the esophagus is a series of precise regional transitions. These physical crossings dictate its vulnerabilities and predict its most fatal pathologies.
If you found this video informative, please like and share, comment what you would like to see next, and subscribe to the channel to get notified about future
Okay, Holly, we
This is the type of faceless animated grow our channel 10 times in 2025, and we created this video in under 5 minutes with TuneB AI. Just type your idea and TuneB turns it into a beautiful 2D or 3D animated video you can use for social media, YouTube, teaching, marketing, or content creation. No camera, no editing skills, no complicated software. In fact, I'm so confident of it, you can try TuneB 60 days money back guarantee. Sounds good? Click the button below and time access before this offer disappears.
फिर झंडा फहरा दे, संदेश अभी सिर्फ वार्म अप है, मैंने ईरान नहीं माना तो सर्वनाश होगा, ये भी डोनाल्ड ट्रंप की तरफ से धमकी दी गई है, बताने की कोशिश की गई है। डीके, डोनाल्ड ट्रंप की तरफ से पहली बार धमकी तो आई नहीं है कि ईरान सरेंडर कर दे, सफेद झंडा फहरा दे, हमला भी कर सकते हैं।
जय हिंद और धन्यवाद संवाद में शामिल करने के लिए। महत्वपूर्ण ये है कि ऐसे शब्द हम बार बार लगातार पिछले 6 महीनों से सुन रहे हैं, और एक तरफ वो कहते हैं कि ईरान तो लगभग समाप्त हो चुका है, उसके पास फौज नहीं है, उसके पास विल पावर नहीं है, उसकी इकोनॉमी हमने ध्वस्त कर दी, और उसके बाद जो है कहते हैं कि भाई सफेद झंडा की जरूरत क्यों पड़ गई, अगर आपने इनको समाप्त कर दिया तो क्यों पड़ी। मैं इनकी रिसर्च टीम को साधुवाद कहूंगा कि जो एनालिसिस दिया है इनके 5 बिंदुओं पर, तो बहुत ही उचित है और सटीक है। महत्वपूर्ण ये है कि एक तरफ उन्होंने कहा कि 60 दिन का जो सीज फायर का पीरियड खत्म हुआ, 17 जून को जो साइन हुआ, और उसमें कोई रुकावट नहीं आएगी, बातचीत करते रहेंगे। अमेरिका को ऐसी क्या आवश्यकता पड़ गई कि उसको टाइम, ऐसा शब्द का बोलना इस्तेमाल करना पड़ रहा है कि टाइमलाइन की आवश्यकता नहीं। साफ दिखाता है कि उनकी रिसोर्सेज जो कि आ रही हैं कि लगभग 70 से 75% उनके जो रिसोर्सेज हैं, उनके एयर डिफेंस सिस्टम है, पेट्रोइट इंटरसेप्टर्स, थार्ड सिस्टम्स और टाइमहॉक मिसाइल्स, वो कंज्यूम कर चुके हैं ऑलरेडी, और अभी जो है यूक्रेन में उनसे मांग रहा है, उनको देने में असमर्थ हैं। तो ये साफ बताता है कि वो टाइम परचेज कर रहे हैं। ऐसे शब्दों का प्रयोग ईरान की तरफ से भी हुआ। उन्होंने कहा कि आप भी जो है जल्दी हम आपको कुछ सप्ताह का समय दे रहे हैं, आप ऑनर करिए हमारे जो एमओयू साइन हुआ था उसको, और अगर नहीं हुआ तो हम बड़ा हमला करेंगे। तो ये कह रहे हैं कि हम बड़ा हमला करेंगे। तो 6 महीने में क्या हुआ? वहाँ की जो डिप्लोमेसी है, उस मिडिल ईस्ट के जो जियोपॉलिटिक्स है, वो थोड़ा सा हिली हुई है, क्योंकि गल्फ कंट्रीज भी एक वादा था सुरक्षा चक्र उपलब्ध कराने का, उसमें भी काफी जो है गैप्स आने लगे हैं। तो कुल मिला के कहा जाए, स्थिति जो है वो अभी भी ऐसी है कि दोनों पक्ष उहापोह में, और लड़ाई अभी
कर रहे हैं। और ग्रीन ने यह भी कहा व्हाइट हाउस में रणनीतिक बैठक हुई है, यानी के इस्तेमाल की अमेरिका की तैयारी।
अब ये कितना दावा सही है, कितना नहीं, ये तो वक्त बताएगा, लेकिन आज से आपको बताते हैं, परमाणु हमले की चर्चा का बड़ा दावा किया गया है कि परमाणु हमले हो सकते हैं। पूर्व अमेरिकी सांसद मार्जरी टेलर ग्रीन ने यह दावा किया है, और ट्रंप प्रशासन की रणनीतिक बैठक में चर्चा हुई। ग्रीन ने कहा, यह अटकल नहीं, स्थिति बेहद गंभीर है।
हालांकि बड़ी बात यह सकती है। युद्ध मानवीय संकट में भी बदल सकता है। कुलकर्णी सर, क्या वाकई अब ये ऑल्टरनेटिव रह चुका है डोनाल्ड ट्रंप के पास कि अब वो टैक्टिकल परमाणु नीति में बदलाव की जो खबरें आ रही थी उसी में रणनीतिक बैठक में इस मुद्दे पर चर्चा हो रही है कि अब परमाणु हथियारों का इस्तेमाल करना जरूरी है?
मुझे नहीं भी कोई भी देश और खासकर अमेरिका हो इस प्रकार के का इस्तेमाल टैक्टिकल हो या फिर स्ट्रैटेजिक न्यूक्लियर हो कभी भी नहीं करेगा, क्योंकि अगर वो करता है किसी भी कारण से करता है तो देख रहा है रूस मद्देनजर रखते हुए मुझे नहीं लगता कि कभी भी अमेरिका, क्योंकि जैसे अमेरिका ने राष्ट्रपति ने
सॉरी टू बटन बंकर बस्टर का इस्तेमाल हुआ इस पूरी टेरेन में जो सब कुछ अंडरग्राउंड सिटी के तौर पर है, क्या अमेरिका के लिए वहां तक पहुंच
से लगातार नेपाल के ऊपर न्यूक्लियर इंस्टॉलेशन जो ईरान के हैं वो तकरीबन 300 फुट हो सकता है, 400 फुट जमीन के नीचे हो, पहाड़ों के अंदर हो, जहां पर इनके बंकर बस्टिंग बॉम्ब काम नहीं कर पा रहे क्योंकि वो अधिक से अधिक 100 या 150 फुट तक जा सकते हैं। उसके मद्देनजर अगर वो सोचते हैं कि हम टैक्टिकल न्यूक्लियर मिसाइल्स का इस्तेमाल करें, कहीं ना कहीं बातचीत चलती, ये तो प्रोपेगेंडा है, एक साइकोलॉजिकल वॉरफेयर है अमेरिका के द्वारा या उनके समर्थकों के द्वारा, या अमेरिका या ट्रंप जो है इस तरह का इस्तेमाल करेगा। दिस इज कॉल्ड म्यूचुअली अश्योर्ड डिस्ट्रक्शन। गलती से भी कर दिया, और अगर ईरान के पास जैसे कहते हैं एक दो अगर न्यूक्लियर बम हैं और अगर ईरान भी उसका इस्तेमाल करता है या किसी के द्वारा दिया गया का इस्तेमाल करता है तो फिर तो
तेल टैंकर पकड़ा है। टैंकर यूएई का बताया जा रहा है। ईरानी शर्त कार्रवाई की गई है। फार्स के मुताबिक टैंकर ने ट्रांजिट नियम तोड़े हैं। तो खबर यह है कि स्ट्रेट ऑफ हॉर्मुज में लगातार दबाव की खबरें सामने आ रही हैं। ईरान ने तेल टैंकर पकड़ा है और टैंकर यूएई का है। ईरानी शर्तें नहीं मानने पर एक्शन लिया गया है। तो टैंकर ने मिल रही है और ईरानी शर्तें ना मानने पर टैंकर्स को रोका जा रहा है। ये भी खबरें सामने आ रही हैं। और ये जो टैंकर पकड़ा गया है, ये टैंकर यूएई का बताया जा रहा है। ये नया अपडेट है।
हालांकि जंग छिड़ने पर फिर हमले की प्लानिंग को लेकर बड़े दावे किए जा रहे हैं, जहां ईरान की खाड़ी देशों पर हमले की तैयारी और खाड़ी देशों के बीच जंग भड़काने की ये तैयारी। कुवैत में जमीनी कार्रवाई का भी विकल्प।
तेहरान का अल्टीमेटम, कूटनीति में तनाव बढ़ जाएगा। तो कूटनीति अगर विफल हो जाती है तो अब और भी ज्यादा तनाव स्ट्रेट ऑफ हॉर्मुज में बढ़ सकता है। अमेरिकी नाकाबंदी पर तेहरान का अल्टीमेटम भी सामने आ गया है।
तो ईरान की रडार पर खाड़ी देश हैं। हालांकि अब खाड़ी देशों पर हमले की योजना को लेकर दावा किया जा रहा है।
हो सकती है घरेलू काउंटर इंटेलिजेंस मजबूत की जा सकती है और मिसाइल उत्पादन भी बढ़ाया गया है।
हालांकि ड्रोन क्षमता भी अब बढ़ाई गई है। यहाँ तक कि आईआरजीसी ने तैयारी की पुष्टि भी कर दी है।
तो ईरान अब खाड़ी देशों पर हमला कर सकता है, इस तरह से आईआरजीसी से चेतावनी दी गई है। डीके पांडे सर, क्या वाकई में अब बड़े पैमाने पर जंग की शुरुआत हो सकती है? हालांकि परमाणु युद्ध तो अलग बात है, ये तो बहुत ही ज्यादा चिंताजनक बात हो जाती है। ये तो सिर्फ और सिर्फ चेतावनी दी जा रही है। तीनों ही देशों की किए गए हैं। तो ऐसे में अगर युद्ध की शुरुआत हो सकती है तो एक बार वैसे ही हमले हो सकते हैं जैसे 28 फरवरी के बाद देखने को मिले थे।
देखिए, जहाँ तक न्यूक्लियर आर्म्स की बात है तो न्यूक्लियर वेपन्स इस्तेमाल करेगा अमेरिका, ये ऐसी बेवकूफ़ी करना नहीं चाहिए उनको, और नहीं करेगा मेरा अनुमान है। द्वितीय विश्व युद्ध के बाद किसी देश ने ऐसी गलती नहीं की है।
Connect your knowledge base, define guardrails and craft your brand voice for authentic human-like support.
ये है कि क्या ईरान की तैयारी इस स्तर पर हो चुकी है कि वो बाकी खाड़ी देशों को सीधे तौर पर अप्रोच से टारगेट किया है। यही वजह है कि खाड़ी देश अब डोनाल्ड ट्रंप से इस बात का जवाब मांग रहे हैं कि आपकी ईरान के लिए रणनीति क्या है। उनको कोई सिक्योरिटी अश्योरेंस नहीं मिला है, इसीलिए वो भी चाहते हैं कि यूएस एसेट बेस यहां से हटाए जाएं।
देखिए, मैं उसी पा रहा था, प्रश्न पक्षता ये था। तो ईरान जानता नैरेटिव होगा गल्फ कंट्रीज के लिए कि अमेरिका जो है पूर्णतः विफल रहा है सुरक्षा प्रदान करने में जो उसने वादा किया था। तो उसके तरीका क्या है उसको अडॉप्ट करने का, ये कितना प्रेशर उस पर पड़ेगा, तनाव में आएगा, स्ट्रेस में आएगा, इसका अनुमान लगाया जाता है कि जब वहाँ पर 19 जो उनके कैंप्स हैं, जहाँ पर उनके ठिकाने हैं अमेरिकी, वहाँ पर उनके आसपास, और उनको हमें पता है कि जो 19 ठिकाने हैं उनको ग्राउंड कवर और एडी कवर देना इतना सहज नहीं है, क्योंकि ऊपर से आपको ड्रोन के हमले आप आते रहेंगे और ड्रोन किस प्रकार से विध्वंसक होते आ रहे हैं हम ये देख रहे हैं यूक्रेन के अंदर भी और मिडिल ईस्ट में भी, ताकि कुछ एक हद तक वो दबाव बनाए रखें। जो बैक चैनल कम्युनिकेशन हो रहा है उसमें अमेरिका में प्रेशर बना रहे और वो अपनी मांगों पूरा कि काम जो है वो चाहता है स्टेरॉइड हार्मोन का उसका एक क्षेत्रराज हो और उसको न्यूक्लियर गैप मिल जाए जिसमें कि वो अपने न्यूक्लियर आर्म्स ले सके।
बिल्कुल, और इसी से जुड़ी धमकियां भी बातचीत चल रही है।
केस हो रखा है इस तरह से। सब चीजें
without a single thought. But when that sequence breaks down, eating becomes a source of intense anxiety. Patients often isolate themselves, taking meals entirely alone to hide their struggle or to manage a very real, persistent fear of choking. In medicine, the sensation of food getting stuck or an inability to swallow, it is the visiction or a lost nerve signal somewhere along the biological descent toward the stomach. To restore a patient's ability to eat safely, doctors must track the path of food downward and map the exact spatial coordinates where the biological machinery fails. This cross-section shows the mouth and throat. Here, the swallowing sequence gathers and directs food downward. In oropharyngeal dysplasia, liquids pour. A patient might develop a Zenker's diverticulum, a sac-like pouch in the upper throat that physically traps undigested food before it descends. Other times, the muscle tissue is perfectly healthy. Signals commanding it have completely failed. Strokes, Parkinson's disease, or ALS sever the neural pathways required to coordinate the throat's complex, rapid movements. To isolate the exact cause, physician malfunction play out in pathologists introduce targeted physical maneuvers, like an exaggerated chin tuck, or modify diets with thickened liquids, using gravity and positioning to safely guide food downward. In severe cases where the airway cannot be protected, the entire throat zone must be bypassed. Doctors insert low-profile feed directly through the skin into the stomach, ensuring the piece comes down to one, protecting the airway before the food ever reaches the esophagus. Downward, we enter the second zone, the esophagus. This vertical tube forts food into the stomach. Insurance food But in esophageal dysphagia, solid food passes the throat only to halt abruptly mid-chest, physically trapped by a narrowed lumen. This delay points to a direct obstruction inside the tube. Acid reflux can scar the tissue, creating narrow peptic strictures. There may be internal webbing, thick tissue rings, or allergic inflammation like gas. Sometimes it's a loss of mechanical pressure. In a condition called achalasia, the nerves surrounding the esophagus die off. The muscles lose their rhythmic contractions, and the lower valve rigidly refuses to open, backing up food like a clogged drain. Doctors investigate the sewing an endoscopic camera to check for physical blockages, and a manometry probe to measure muscle strength. This split-screen visualization disorganized high-pressure spikes of an esophageal spasm on the right. Because these failures are highly mechanical, the treatments are equally direct. If an internal stricture blocks the tube, a gastroenterologist balloon down the esophagus and inflates it, physically stretching the tissue. If tense, unyielding muscles are causing the jam, doctors can inject Botox directly into the sphincter to force relaxation, or perform a specialized surgery to cut the frozen muscles entirely from the inside. Lower esophageal treatments treat the body as a plumbing and wiring system. Success relies on clearing pipes and restoring necessary pressure to push solids into the stomach. Restoring a safe swallow returns a patient to the social world. The human swallowing mechanism relies on dozens of intersecting muscles, nerves, and valves. Yet by accurately mapping exactly where that system halts, physicians can deploy targeted mechanical solutions to bypass or repair the damage. This makes early assessment critical. Rather than adopting dangerous eating habits or quietly tolerating the discomfort, patients experiencing this difficulty should seek an evaluation from a gastroenterologist or a speech-language pathologist immediately. Repairing the biological transit tube ultimately achieves a much larger goal. It returns physical safety, restores personal independence, and allows patients to re-engage with a vital piece of human connection. For most of us, eating is an afterthought. But the moment you swallow a bite of solid food and feel a sharp, burning sensation in your bone, a routine reflex becomes a source of dread. This pain signals a breakdown in a complex and multiple cranial nerves in 3 distinct phases. It begins in the oral phase, where you chew food and mix it with saliva to form a bolus, which the tongue then pushes toward the back of the throat. In the pharyngeal phase, timing is everything. A flap of cartilage called the epiglottis folds over the windpipe to protect your airway, while the upper esophageal sphincter opens to guide the food into the throat. Finally, during the esophageal phase, rhythmic muscle contractions called peristalsis wave down the length of the tube, driving the esophageal sphincter relaxes to allow entry. When any part of this process causes acute pain, it is medically classified as odynophagia. This differs from dysphagia, which refers to the physical sensation of food getting stuck. Odynophagia is the specific experience of pain during the act of swallowing itself. This sensation indicates that the esophageal lining has been compromised. The pain acts as a warning that structural, chemical, or inflammatory damage is occurring somewhere along the anatomical pathway. One primary source of this damage is infectious esophagitis. These infections are most weakened immune systems, such as those undergoing chemotherapy, organ transplant recipients, or individuals with HIV. Different pathogens leave distinct signatures on the esophageal wall. Candida albicans creates thick, white fungal patches. P. simplex virus results in a cluster of small, shallow ulcers. Large, deep, isolated erosions that penetrate further into the tissue. Chemical damage often stems from gastroesophageal reflux disease, or GERD. When the lower esophageal sphincter fails to close properly, stomach acid pushes back up into the esophagus. Over time, this chronic acid exposure inflames the delicate lining, creating a persistent burning sensation. Medications can also cause localized burns, a condition known as NSAID lodges in the throat because it was swallowed without enough water or taken immediately before lying. More severe chemical damage occurs through corrosive injury. This cross-section shows the difference. Acids cause coagulation necrosis, which forms a clumping scab on the surface. Alkalis are often more dangerous, causing liquefactive necrosis that melts through the cellular structure and penetrates deep into the esophageal wall. Regardless of the source, fungal infection, a trapped pill, or corrosive chemicals, the resulting inflammation sensitizes the nerves. When muscles contract during a swallow against this damaged tissue, triggering an immediate pain response. Some causes are linked to the immune system. Eosinophilic esophagitis is an allergic condition where white blood cells called eosinophils accumulate in the esophageal lining. This is frequently seen in patients who already manage asthma, eczema, or specific food allergies. The most critical concern is esophageal cancer. In these cases, the pain of odonophagia is often early detection is vital, as these tumors surrounding tissue. Differentiating between a simple infection and a malignancy requires a clinical evaluation. This process begins with a physical exam and a detailed history of when the pain occurs and what types of food trigger it. To see the damage directly, clinicians use an upper GI endoscopy. A flexible camera is guided down the esophagus, providing a high-definition view of the lining. This allows for immediate identification of ulcers or growths and enables the doctor to map of the esophageal movement. As the patient swallows a contrast liquid, flow in real time. If there is a narrowing or a motility disorder, the fluid pools above the obstruction, revealing the exact location of the problem. Identifying the specific mechanism of injury, whether it is a bacterial infection, a chemical burn, or a structural narrowing, is the only way to develop an effective treatment plan and prevent long-term damage. Treatment is dictated by the laboratory findings. For infectious esophagitis, physicians prescribe specific antifungal or antiviral medications to eliminate the pathogen and allow the esophageal lining to regenerate. Managing GERD or allergic inflammation involves reducing the irritants. Patients often use proton pump inhibitors to stop acid, combined with dietary changes to avoid triggering further immune responses in the esophageal tissue. Mechanical issues require direct intervention. Lodged objects are removed endoscopically, while esophageal cancer may require a combination of surgery, chemotherapy, or the placement of a stent to keep the airway and food passage clear. Ignoring painful swallowing can lead to severe complications, perforation of the esophageal wall. Many of these conditions are preventable. Treating acid reflux early, taking medications with plenty of water, and remaining upright after meals can significantly reduce the risk of chemical or the throat. When the underlying cause is addressed, the esophageal lining heals. The coordinated contractions of the swallowing reflex return to their natural state, allowing food and liquid to pass into the stomach without pain. Odonophagia is a clinical sign of active esophageal injury. Because the causes range from minor infections to serious malignancies, any persistent pain during swallowing requires a professional medical evaluation.
Video informative, please like and share, comment what you would like to see next, and subscribe to the channel to get notified about future informative videos.
This is part 1 of the videos about palliative care for human esophagus, a smooth, muscular tube that effortlessly carries food and water already progressed too far for surgical removal. For these irresectable cases, the harsh reality is a life expectancy of fewer than 6 months. The immediate daily crisis becomes dysphagia. It starts as a slight difficulty swallowing, but eventually progresses into a inability to pass food, water, or even normal saliva into the stomach. When a cure is no longer physically possible, the medical strategy shifts to reopening that locked passageway to minimize suffering and maximize the patient's quality of life. Clearing this blockage is a direct mission to save the patient from the physical turn to a mechanical bypass. This approach relies on physically wedging the collapsed pathway open, a practice that began with early forms of esophageal intubation. In the historical Celestin's tube procedure, a pilot wire passes through the stricture and out an incision in the stomach. This wire drags a rigid tube down until it wedges against the tumor. Excess tubing is cut away and the wound closed. Today, that invasive surgery has largely been replaced by a much more elegant tool. Doctors use flexible endoscopes to deliver self-expanding metal stents directly into the narrowest part of the stricture, where they bloom open and steadily push back the tumor walls. The benefit of diseased tissue carries physical risks. About 10% of the time, the esophagus. Patients might also suffer from severe acid reflux or find that the tooth gets clogged with food or overlapping tumor growth. Mechanical solutions secure the airway and allow the patient to eat immediately, but they do require the person to adapt to a permanent physical stressor lodged inside their anatomy. When a tumor shape makes path, a fiber optic tip delivers pulses of light to vaporize malignant tissue, clearing a path upward. For higher tumors, bipolar dithermy probes are preferred. These probes use direct thermal heat to destroy the blockage. Alternative. Because these thermal tools vaporize the obstruction rather than stretching the esophageal wall, the incidence of perforation drop. Ablation does not work instantly. The patient has to endure a waiting period of up to a full week for the treated tissue to clear before they can swallow properly. If the tumor aggressively regrows, the patient will have to return for repeated sessions just to keep the passage clear. By choosing energy ablation, doctors trade the immediate, riskier fix of a mechanical stent for the destruction of tumor cells, requiring the patient to push through a tough recovery week to regain their ability to eat. For very specific, superficial cancers, there is photic therapy, or PDT, to the malignant cells. During an endoscopy, the doctor floods the area with a specific wavelength of red light. This light activates the chemical, triggering a cytotoxic reaction that destroys the tumor's blood supply, causing the tissue to wither away. But PDT is highly restricted. Against large advanced cancer, tissue intact, causes a risk of hemorrhage, and the symptom relief is often poor and delayed. When a tumor creates an absolute, impassable blockade that rejects both mechanical stents and thermal ablation, the absolute final option is a gastrostomy. It successfully delivers vital calories to keep the body alive. It cannot restore the primary function of the throat. The patient is still left unable to swallow their own saliva. Whether physically braced open by a metal stent or cleared with targeted lasers, the primary goal is to achieve this, an open, functioning pathway. For the patient, this space represents the return of basic human autonomy. It allows them to eat soft foods and comfortably manage their own saliva, removing the constant fear of choking. Palliative care at this stage uses engineering and physics to prioritize the patient's comfort. Cancer. But these structural tools ensure that the final months are defined by dignity, not distress. Stay tuned, as we will explore more interventions and symptom management strategies in Part 2 of our series on palliative care for esophageal cancer.
Welcome to Part 2 of our esophageal cancer series. In this video, we'll explore focuses on relieving symptoms, restoring swallowing, maintaining nutrition, controlling pain, and improving quality of life. We'll cover esophageal stents, feeding procedures, radiotherapy, chemotherapy, and other supportive treatments using detailed 3D medical analysis. Let's begin.
In a healthy state, the esophagus functions as a simple, vital muscular pathway for sustenance, moving food and liquids to the stomach. When squamous cell or adenocarcinoma tumors develop, the mass encroaches on this passage, creating a bottleneck that causes dysphagia, the inability to swallow. This restriction is often permanent. Over half of advanced esophageal cancer patients are unfit for curative surgery. When normal swallowing is blocked, a patient's health and quality of life deteriorate rapidly, as nutrition and hydration become physically impossible. In these cases, shifts from the stent uses mechanical force to push the tumor back, instantly clearing the esophageal pathway. Uncovered metal stents allow esophageal tissue to project through the mesh. This anchors the device, but the tumor can eventually grow back through the grid. Plastic-covered stents block this ingrowth, but lack mechanical grip, making them much more likely to migrate downward. Calculation between the risk of the stent being blocked by new tumor growth and the risk of the device physically sliding into the stomach. If the tumor is completely irremovable and the patient has a limited life expectancy, surgeons may attempt a high-risk bypass operation to manually reroute the digestive tract. These mechanical solutions solve the immediate plumbing problem, but they do not address the underlying biological cause of the obstruction. To slow the actual growth of the tumor, oncologists move to the cellular front, using external beam radiotherapy to inhibit the primary tumor's progression. This chart shows the standard timeline for external radiation. Fractionated doses delivered 5 days a week for
These daily increments eventually sum to a threshold between 5,000 and 6,000 centigrade. This intensity can be difficult to tolerate. High-dose radiation may lead to serious complications, such as the formation of a permanent fibrous stricture or a dangerous fistula between the esophagus and the respiratory tract. A more localized alternative is brachytherapy. In this procedure, a specialized applicator is used to deliver radiation directly to the tumor from the inside. Brachytherapy delivers a rapid dose of 1500 centigrade. As this heat map illustrates, the radiation is hyperconcentrated within the tumor mass, which helps spare the adjacent healthy tissues from damage. Since esophageal, their single-agent response rates are often poor, can be debilitating. Modern palliative care increasingly relies on a multimodal approach, combining mechanical, localized, and systemic treatments to address the limitations of each. There is a significant synergy when cyclical chemotherapy, such as cisplatin, is combined with external radiotherapy. This combination produces measurable disease shrinkage in approximately 60% of patients. Clinical contradiction. When systemic chemotherapy is highly effective, the tumor shrinks away from the esophagus walls. If that tumor was the only thing anchoring a metal stent in place, the stent loses its grip and falls into the stomach. Because of this risk, doctors avoid placing stents in patients undergoing effective chemotherapy, opting instead for laser therapy to manage the opening of the esophagus. Palliative care for esophageal cancer remains a high-stakes balancing act between physical engineering and cellular biology. By coordinating these treatments, clinicians can restore the basic dignity of eating and drinking for those facing a terminal diagnosis.
If you found this video informative, please like and share, comment what to see next, and subscribe to the channel to get notified about future
Meals take longer, food feels stuck, and symptoms slowly worsen. Over weeks, even soft foods become hard to swallow. The doctor considers causes of progressive swallowing difficulty, including benign strictures, achalasia and esophageal cancer. They evaluate whether there's a blockage, a motility issue, or malignancy. If cancer is suspected, further tests are required. The workup advised by doctor focuses on confirming diagnosis of esophageal cancer, staging when radiotherapy is appropriate. Each step builds on careful assessment and imaging.
Evaluating the esophagus begins by observing function. When we introduce a dense liquid contrast, like barium, we can visualize the macroscopic flow through the esophageal lumen and map out sudden anatomical bottlenecks. This standard barium esophagram provides a highly accurate initial morphological baseline. By utilizing air contrast technique, formation of tight annular strictures. To establish a diagnostic baseline, we contrast this. A benign lesion typically presents as a smooth, symmetrically tapered narrowing. A malignant lesion, however, actively destroys the surrounding tissue architecture, creating an irregular, jagged profile. Clinically, this jagged, asymmetrical narrowing of the digestive is classified as the malignant rat tail filling defect. They result in varying degrees of proximal dilation. The healthy esophagus balloons out above the blockage. Malignant lesions, by contrast, rigidify the wall, meaning this proximal dilation is rarely seen. While morphological imaging provides a high clinical index, macroscopic structural data alone is circumstantial. It maps the shape of the defect, but it cannot definitively prove the presence of cancer cells. Because of this limitation, there is an absolute clinical rule. Endoscopy must be performed in all cases where an esophageal cancer is suspected based on the initial barium study. Passing an endoscopy into the lumen serves three critical functions. It allows for direct visual inspection of the mucosa, the extraction of physical tissue through biopsy, and mucosal brushing for highly specific cytological examination. Once cytology, typically squamous cell carcinoma or adenocarcinoma, the clinical objective shifts immediately. Diagnosis is complete. The priority is now tumor staging. The central challenge of esophageal staging lies in the anatomy itself. We have to accurately measure exactly how deep the tumor has penetrated through the thin esophageal wall and into the surrounding mediastinum. Tissue diagnosis only proves the disease exists. Preoperative survival algorithms dictate that we must precisely map the primary anatomical invasion depth before a surgeon can even consider opening the chest. To map this invasion, the definitive preoperative method is endoscopic ultrasonography, or EUS. It is our primary tool for microstaging the main lesion and checking for regional lymph node involvement. EUS functions by emitting sound waves from the esophageal lumen. These echo back, revealing the microscopic concentric layers of the esophageal wall. On EUS, a carcinoma presents as a hypoechoic mass. We see it disrupting and penetrating these layers, giving a precise measurement of invasion depth. However, EUS has a severe mechanical limitation. The endoluminal ultrasound probe requires physical space to operate, and it cannot pass through highly stenosing, or tightly narrowed, lesions. Because these tumors often choke off the assembly, attempting EUS is technically impossible in a significant percentage of patients. When strictures block the probe, the fallback protocol requires a return to double contrast barium studies. We use the liquid contrast to map the total length of the advanced carcinoma and locate its distal segment.
This fallback has obvious limitations. While barium can successfully reveal secondary carcinoma sites and overall tumor length, it completely fails to evaluation of the primary tumor mechanical obstructions the tumor creates. Resolving the local depth is only half the staging process. We also require macro staging to establish resectability and check for distant metastasis, making CT scanning and abdomen mandatory. Where EUS works radially from inside, CT evaluates anatomy using external axial slices, stacking top-down views of the thorax. This orientation allows CT to identify tracheobronchial invasion. We look for inward bowing of the posterior tracheal wall or airway displacement. But CT has blind spots. It cannot accurately assess diaphragmatic invasion because the oblique diaphragm crosses through flat axial planes. Its primary strength lies lower down, visualizing upper abdominal and infradiaphragmatic lymph node metastasis. To cover the imaging blind spots, surgical adjuncts are mandatory. For lesions in the upper and middle thirds of the esophagus, a bronchoscopy is performed to directly rule out tracheal and bronchial invasion. For adenocarcinomas located in the distal esophagus, laparoscopy is critical. It allows direct visual detection of transperitoneal spread and superficial liver metastases that the CT scan might miss. Accurate staging demands a multimodal matrix. No single perspective can resolve both the microscopic wall depth and the macroscopic systemic spread. Once staging is complete, we move to treatment planning. For squamous cell carcinoma, this introduces a major clinical paradox regarding radiotherapy. Squamous cell carcinoma is highly radiosensitive. The tissue readily absorbs and is destroyed by radiation. Yet, when radiotherapy is utilized against clinical reality, the average 5-year survival rate following radiotherapy alone is less than 10%, peaking at a maximum of just 17%. This failure is not a biological defense mechanism of the tumor. It is a mechanical problem dictated by the tight anatomical confines of the mediastinum. To cure the cancer, you need radical radiation loads of 5,000 to 6,000 rads. Because of the surrounding anatomy, delivering this safely is strictly confined to cervical esophageal carcinomas located higher up in the neck. The theoretical vulnerability of the tumor is entirely of the surrounding thoracic cavity. If we attempt to apply those radical curative radiation doses lower down to the thoracic esophagus, it causes devastating collateral damage to adjacent vital organs. The lungs are highly vulnerable, leading to severe radiation. Suffers profound structural damage, resulting in tight post-radiation strictures or the form of fistulas. Deeper inside the mediastinum, high-dose exposure leads to irreversible spinal cord injuries, effusions, and constrictive pericarditis around the heart. Because of this damage profile, we have to redefine the actual clinical utility of radiotherapy for thoracic lesions. It is primarily a tool for palliation, not cure. The palliative protocol utilizes low-dose administration between 2,000 to 3,000 rads. This precise dosage is calculated specifically to alleviate distress symptoms like severe pain, dysphagia, and active bleeding. Secondarily, it serves as a preoperative adjunct, used to shrink the tumor margins and improve the odds of surgical resectability before an operation. Within the thoracic cavity, radiate off, strictly modulated to manage terminal symptoms or clear the way for surgical extraction.
Here's the thing. With esophageal cancer, surgery isn't always on the table. If the cancer has reached distant organs, wrapped around or invaded vital structures, or your overall health makes a big operation too risky, doctors may choose a different path. The goal then shifts from cure to comfort. That's where palliative treatments come in. You might reduce pain and improve swallowing. Sometimes a stent, a small tube-like support, is placed to keep the esophagus open so food and liquids can pass more easily. These options can't always erase the disease, but they can often ease distress, help you eat, and give you more time with better quality of life. Your care team will explain the plan, compare benefits and side effects, and adjust. Pain relief and supportive care become central to quality of life. Throughout, the patient is cared for by a team. Upper GI surgeons, oncologists, gastroenterologists, radiologists, pathologists, dietitians, nurses, and palliative care specialists. The most important message: don't ignore persistent.
If you found this video informative, please would like to see next and subscribe to the channel to get notified about future informative videos.
The esophagus has one main job: move food from your mouth to your stomach. It's a simple, highly elastic muscular tube. Within the gastrointestinal tract, cancer here is relatively rare, accounting for only 7% of malignancies. But its anatomical location and the way it develops present a difficult clinical picture. The difficulty begins with how quietly the disease starts. Long before any alarms go off, a patient might notice a vague sense of indigestion, a mild discomfort behind the breastbone, or perhaps slow, hidden blood loss resulting in mild anemia. Eventually, these quiet signals give way to the disease's hallmark symptom. Over time, that internal obstruction tightens until even liquids, and eventually a person's own saliva, cannot pass. What makes this disease particularly difficult to pin down right now is that its biological profile is shifting. The frequency of different cell types and where they appear is no longer following historical patterns. Because the cancer's behavior, triggers, and survival rates change depending on where the tumor originates, we have to map the disease anatomically. By the esophagus from top to bottom, we can see exactly how this threat forms and how it spreads. Looking first at the upper and middle sections of the tube, we see the form of squamous cell carcinoma. This specific cellular mutation is heavily tied to age and lifestyle. The majority of patients are between 45 and 75, with a sharp spike in risk linked directly to heavy tobacco use and excessive alcohol consumption. But there is also a striking geographic incidence rates for squamous cell carcinoma spike across a distinct belt of the globe, stretching from the shores of the Caspian Sea across to northern China. In these specific areas, the triggers are largely environmental. Agricultural practices can lead to the fungal contamination of food stores, producing carcinogenic toxins. When these are combined with regional nutrition, structural issues can also create an opening. A condition called achalasia causes the esophagus to severely dilate and lose its ability to push food downward. Patients with this condition face a 10-fold increase in squamous cell cancer, often developing tumors at a much younger age. While tumors in the upper regions are specific environments and habits, we find a different landscape as we get down to the lowest third of the esophagus, just above the entrance to the stomach, we hit a different biological landscape. Here, the dominant pathology is adenocarcinoma. This chart tracks the progression in the lower esophagus. In several countries, 60 to 75% of cases, with its incidence growing by 8% every year. This data follows the rise of chronic acid reflux. As stomach acid repeatedly burns the lower esophagus, the persistent inflammation causes the normal tissue to change. It can develop into Barrett's esophagus, where the lining is replaced by tissue similar to the stomach or intestines. Regardless of the cell type, this organ is poorly equipped to contain them. The cancer spreads locally by horizontally beneath the top layer of healthy tissue, extending up to 3.5 centimeters out from the visible tumor cell.
procedure required highly invasive surgery, opening the patient with large. To be tested without getting dropped.
limitations to stretch the scar, and in severe cases, reconstructive surgery to restore a safe passage. The key lesson is timing. Early recognition and timely care help protect long-term swallowing function, and throughout your 3D journey helps you understand what's happening.
Non-accidental events involving much higher